Well, I'd like to first of all give honor to a special guest in our midst, the Commissioner of the National Population Commission, Chairman, my apologies, sir, Dr. Aminu Yusuf. Please, can we give a round of applause? We welcome you here today, sir. Thank you for gracing our presence.
You're especially welcome. So I think I just want to come down and then I'll get like 2 or 3 expectations from today's discourses. I know communication is at the heart of today's important discourses. And like we often say, we are the system that fails us if we are not doing what every right-thinking members of this society should be doing, which is communication. And communication, as we all know, is at the heart of everything we do. Once we miscommunicate, it's just like the doctors and the patient, then the whole idea of that important diagnosis will be missing. The whole idea of even historical medical care will be missing. So can I have 1 or 2 persons volunteer to tell me what their expectations for today would be? Or do I just look at your beautiful faces and then pass on the mic? All right. Sir, do you want to help me? Yes. Ma'am, do you want to help me? What are your expectations for today? You just want to listen? You want to, pass on the information from here? Because we're all stakeholders. As a patient, you're a stakeholder. As a communicator, you're a stakeholder. As a legal practitioner, you are a stakeholder. Please say something to us. What are your expectations for today?
Thank you for putting me on the spot. So my expectations, really, first my background, so I'm a doctor, and so as you said, communication is very important. We're taught that right from medical school, and first in just getting information out of patients so we can reach the right diagnosis, but also to communicate that to patients, but also for patients to be able to actually hear what's being said, and to empower patients to be able to take it in and carry, because patients really are, I tell people, they're the custodians of their medical history. So I think that what I hope to get out of this first is just to hear people's experiences, and to start the conversation about how we can, as medical practitioners and as patients, actually just do better in what we do. All right, thank you.
Thank you so much. Because she is a doctor, I think she's very much interested about what the patients here today will have to say and how they have also viewed medical practitioners, doctors, and all of that. I wonder why, do we even have the security personnel in this room? I think there should be one of the most important stakeholders to be here, because most of the time we hear that the issues of some persons harassing doctors, just like the ones that have been seen viral on social media lately. But because today's discourse is about humanizing communication and all of that, so I'll quickly want to pass on the mic to my co-MC. We pretty much will take the welcome address in a few minutes, yeah. But before we do that, we may like to also invite the convener shortly. Who is the visionary behind today's event, to come tell us? But like I said, we'll invite her shortly. So
without further ado, we would like to have the welcoming address. Please, let's welcome to the stage
Okay, so we're still waiting for the facilitator for that, Dr. Akerele, who is very much on his way here. He's here? Oh, fantastic. Fantastic. So at this point,
So without further ado, with a round of applause, let's welcome Dr. Isaac Olubanjo Akerele for the welcome address. Can we give a round of applause, please?
Dr. Isaac is the Director General of the Nigerian Doctors Foundation. He's a healthcare provider. He will be giving us his welcome address today. He is a trailblazer. Please, can we give a round of applause for Dr. Isaac Akerele?
Good morning, highly distinguished guests, leaders of thoughts, trainers, and scholars in the house. I'm privileged. I don't know. It has to be changed. For me. MC, do you have a pointer? We go through this quickly. Yeah, thank you. Distinguished girls, panel, discussants, colleagues, patients, patient relative, members of health professionals, ladies and gentlemen. It's a privilege for me, to be here to give this in this serene environment. It is an honor to welcome you to the inaugural Patient Doctors Forum, convened to explore a subject at the heart of good healthcare, effective communication, and advances at a patient care center. Today, we bring together two essential partners in health care system: those who seek the care and those who provide it. To learn from one another, to listen, and to build practical ways to improve outcomes, satisfaction, and quality of care for patients across our dear country and beyond. The keynote speaker is no other person than the media giant in the field of family medicine, Dr. Lawrence Akimosis, who will do justice to the theme of this year's activity, Humanizing Healthcare in Nigeria. Empowering patients, caregivers, and providers, while the distinguished address will be delivered by our own erudite professor of medicine at the Yakubu Gowon Teaching Hospital, that Professor Anoma. Thank you for accepting to be here. We meet at a crucial moment. Advances in clinical science and technology have expanded what medicine can do, but the full benefit of those advances is realized only when care is delivered in ways that respect patient value, preferences, and need. Patient-centered communication is not a soft add-on. It is a core clinical skill that helps endure accurate diagnosis, improve adherence to treatment, reduce unnecessary tests and readmission, and strengthening trust between patients and the providers. Those improvements translate to better health outcome, and reduce waste at a scale that brings meaningful gain to our national economy. Today's forum, through open and panel discussion, is designed with three interlinked goals. First, to deepened understanding of what effective patient-centered communication looks like in everyday practice. Clear explanation, active listening, shared decision-making, and culturally sensitive interaction. Secondly, to identify practical strategies and system change that makes just communication feasible and sustainable in busy clinics and hospitals of ours. Thirdly, to create channels on ongoing dialogue between patient and provider so that policies, a protocol, policy protocol can be, evidence-based. Over the course of this curriculum, you hear from the clinician, patients, advocates, providers, and communication experts. We will examine real cases, review evidence on impact of a patient-centered approaches, workshop, concentrate tools, and from communication checklists and teach back method to appointment and scheduling continuity practice. That teams can implement the team that can be implemented immediately. Importantly, it will include voices of patients and caregivers, whose perspective reminds us why respective, clear, and compassionate communication matters. For clinicians, I invite you to reflect on how your words, tone, and body language influence not only a single consultation, but the patient willingness to engage in long-term care. For patients and caregivers, thank you for choosing to be part of this conversation. Your insight will shape how services meet your real needs. For healthcare policymakers, healthcare providers and policymakers, consider the operational changes and investment to make patient-centered communication standard practice, not an option. Let us all recognize the measurable effect. Evidence shows that effective communication reduces medical error, increases treatment adherence, shortens hospital stays, and improves patient satisfaction scores. These outcomes improve population health and reduce costs, strengthening workforce productivity, contributing to the national economic growth. As we begin, I encourage open, respectful, courageous dialogue, shared access, surface barriers, and propose solutions with implementation in mind. Commit to taking at least one concrete change back to your workplace or community after this forum. I would like to thank the thinkers behind this innovation, the organizers, the sponsors, our speakers, and every participant for making this gathering possible. Your presence signals a shared commitment to healthier patients, stronger health system, and a more prosperous nation. I will now join all the special guests of honor, distinguished scholars, trainers, mentors to declare the inaugural Patient Dr. Forum open. May our discussion be frank, our listening attentive, and our action practical and sustainable. Thank you.
A little bit more round of applause, please, as he goes back to his seat. All right, we're getting to where we are going. So earlier on, I wanted to acknowledge a special guest. I didn't do it well. So allow me, please, to reintroduce in our midst, with acknowledgement, we have the Chairman, National Population Commission, Tauban Wishishi, Dr. Amin Yusuf. A round of applause, please. Thank you, sir, for coming. And also in our midst, we have the chairman, Management Committee Association for Advancement of Family Planning, and the convener of 5 Million Women Database, Dr. Ejike Oji. A round of applause for him. Thank you, sir, again for coming.
All right, at this point, we would like to invite our visionary convener of today's event. She is no other person than the phenomenal Dr. Temitope Oyetunji. She is the founder of the PDFN. She empowers patients through education and advocacy, providing tools for effective communication, and offers specialist training for healthcare providers to improve clinical outcomes. Please, ladies and gentlemen, let's give a round of applause for Dr. Temitope Oyetunji.
To those of you who've been wondering who the face behind this initiative is, here
Please,
she
you
goes.
can do more. A round
Come
of
on, a round of
applause.
applause. Thank you.
Thank you very much. Distinguished ladies and gentlemen, I am so happy that this day has finally come. This is a day that has been in the making for 5 months now, and it's finally here. I want to thank you all, our invited guests. Thank you so much for coming. I appreciate you all. And thank you everyone that has come this early to witness this inaugural forum. This is the first of its kind forum that is happening in Nigeria. We have not had this before. Yes, where patients and doctors, other healthcare workers, stakeholders in the health sector come together to discuss issues that has to do with health. So I think this is, if nobody will say it, I think it's phenomenal. Yes. All right. So I thank Dr. Akerele for giving that professorial welcome address, but I'm going to do it a little bit differently. Yes. So, okay. All right then. Okay. Fantastic. Okay. Media guys. All right. Sorry to alarm you, but this is how we're going to start. So, those are my sneakers. Just about a year ago, I was attacked by robbers in broad daylight in the city of Abuja while I was taking a walk. And I was stabbed. My phone was stolen. I found myself in the hospital following that. And in the days that followed that attack, I did something that I usually do when I get into tough situations. I wrote. In the beginning, I was just writing just to recount the event and share with family and friends. But after I had written about 20 pages, I knew that, okay, this was more than just what I would share with family and friends. So I turned that into a book, a memoir, and then I published that. But that was the beginning of something. Before then, I had started so many books and never finished them. But that became my first book. So that jinx was broken with that first book that I wrote. And after that, just shortly, about 2 months later, I wrote The Smart Patient. Then I wrote a third book and then a fourth book. And all those books gave birth to the forum. So if you want to know how the inaugural Patient Doctor Forum really began, it began with a knife, a pair of ruined sneakers, and a decision to not let that pain be wasted. Okay, but that is just only half the story. This is my father, Gabriel Oyetunji. Now, I will not go into details. It's late now. But I will say that I wrote The Smart Patient because of my experience when I became a patient relative when he was ill. I witnessed somebody I loved becoming dependent on a healthcare system that did not always see him the way I saw him. and he didn't receive the care that I think he deserved. Although I can't change that, I'm doing the next best thing. Today, we are giving the Gabriel Oyetuji Award for Compassionate Care, which will be presented to a doctor who has been nominated by patients as someone who gives genuine compassion, genuine attention, and genuine humanity to the patients in front of them. So even though my father didn't get that when he needed it, today someone will be celebrated for being exactly that kind of doctor. That is the best tribute I know how to give him. I thought he would be excited about that. All right. Thank you very much. Okay. So how many of us have seen this sign? Police is your friend. Right. Now, I'm not going to comment on the gap between this slogan and the reality. We are all Nigerians. We know the answer. But why was this slogan necessary in the first place? Because there was distrust. Distrust toward an institution that was supposed to protect people. And whether that distrust was justified or not, the distrust had consequences. It kept people from fully engaging with the very service that was meant to help them. So stakeholders in that sector tried to change the orientation. They tried to rebuild trust. And it made me wonder, what about us doctors, nurses, healthcare professionals? Do we have a phrase, a slogan, something that tells the Nigerian public who we are and what we stand for? Because right now, if you sample opinion of the people in this room who are patients, what they think about doctors, you might be surprised what you learn. Some people will say doctors are arrogant, doctors that don't listen, they don't care, they care about money, they're always fighting for salaries. Now, I'm not standing to tell you that those experiences are entirely untrue, but I am standing here to say that that is not the whole story. And it is definitely not the story we want you to leave this forum with. So, if the police is your friend, then let us give Nigerian healthcare something better. Something earned, not just declared. Your doctor is on your side. Because the truth is this, the way patients approach healthcare matters. The mindset they bring into the hospital really affects the kind of care they receive, the questions they ask, and the information they share. And that ultimately affects their outcomes. So, rising from this forum, the stakeholders in this room can say clearly to the Nigerian public that your doctor is on your side. Okay, so I have walked in 3 pairs of shoes that very few people wear simultaneously. I'm a doctor. I know what it is to sit on that side of the desk. The pressure, the patient load, the exhaustion, the moments when you want to give more than the system will allow you to. I've also been a patient, and I know what it is to sit on that side of the table as well, vulnerable, afraid, needing someone to explain what is wrong with you in a language you can understand. And I've also been a patient relative. I know what it is to sit beside someone you love and watch the system process them rather than truly seeing them. Being all these 3 things does not make me an expert, but it does give me a particular kind of clarity to know where the gaps are and what it might take to close them. This forum was born from that clarity. It's not theory, it's not research, it's a lived experience. Transformed, I hope, into something that serves more people than just me. Now, I want to tell you something about my colleague, Dr. Akerele. When I started this initiative, he was one of the first people who believed in it. He was excited. He opened doors. I could tell you some guests in this room that are here because of him. I'll keep that to myself, yeah. But he helped a lot. And he used to say to me, he would say, I like your passion, but it's naive. And honestly, he was right. I'm that kind of person who looks past reality. Or perhaps more accurately, the one who refuses to accept that reality cannot change. I genuinely believe that once people saw the value of what we were doing, people were going to rally around it. So I would meet people, pitch the vision, and they would say, oh, what a beautiful initiative. But then when it came time to support financially, the tone will change. What you're seeing in this room today was not built on grants or institutional funding. It was built on grit, on personal financing, on family members who believed before the world did. Shout out to my mom. I know she's watching now. She was the first person that contributed to this initiative. And then she went a step further. She forwarded the message to all the people in her contacts that support this initiative, please. Thank you, Mom. I'm sure she's watching. It was built on friends who showed up in the ways they could, and a few generous organizations who chose not just to admire the vision, but to support it meaningfully. The forum was built on the kind of stubbornness that some people call passion and other people call foolishness. I have made peace with being called both passionate and... So when I lay in the hospital after the robbery, I was bitter. Of course, when my father died, I was pained because it was preventable. But when I look across this room today, what I feel most is gratitude. Gratitude that I made a choice, although it was not an easy choice. The choice to let these experiences become fuel rather than fire that destroys. To let what broke me open become something that could open doors for other people. That is what this forum is. To every patient who has ever left a consultation more confused than they walked in, to every doctor who has wanted to give more but limited by the system around them, to every caregiver who has fought for someone they love inside a healthcare system that did not always truly see them. This forum is for you. But let me be very specific about what this forum is actually trying to change, because a forum without a clear goal is just a conversation. PDF Nigeria exists to drive 3 kinds of change. Number 1, better conversations. How a doctor speaks to a frightened patient, how a patient learns to ask questions they are entitled to ask, how both sides begin to see each other not as opponents but as partners. That is a cultural change. And it begins the moment a doctor and patient choose to show up differently to the encounter. The second thing we're hoping to change is, or to achieve, is better systems. Because communication does not happen in a vacuum. Systems shape behavior. So the patient load that gives a doctor 6 minutes per consultation, or the waiting room that makes a patient feel invisible, or hospital policy that is not conducive for communication, these things don't encourage communication. And we cannot keep asking healthcare workers to communicate better inside systems designed against meaningful communication. So the systems must change too. The third thing is better policies. Communication skills are still not treated as a core clinical competency in many parts of Nigerian medical training. There is no national standard for patient communication across our health facilities. Although, to be fair, I did visit Federal Ministry of Health 2 weeks ago, and I was shown a manual about interpersonal communication in hospitals. But this is my 13th year of practicing, and I had never heard about it before. That must change. And there are very few accountability structures around how patients are spoken to or not spoken to. So these are the changes we hope to achieve with PDF Nigeria. 3 changes, 3 levels, all necessary, non-sufficient on their own. So today, we will also be unveiling books that was born from everything I've just talked about. The Smart Patient, which is for every Nigerian who has ever sat in a consulting room unsure of what to ask or whether they are even allowed to ask questions. The Smart Parent, which is for every parent trying to navigate the terrifying and beautiful first weeks of a new life without a map. And the Smart Doctor, which is for every clinician trained in the science of medicine, but never formally taught the heart of the relationship. These books are practical, they are written in plain language, and they are my attempt to place useful healthcare knowledge directly in the hands of people who need it the most. Because informed patients navigate healthcare better, and informed healthcare providers care better too. The books are available today, and in many ways, they are the reason why this forum exists. Now, I told you earlier that this forum was built on grit, on personal financing, on family members, and on people who chose to support the vision before it became visible. That is what has brought us this far. But to take us further, to make this an annual platform, to distribute these books across primary healthcare centers, to train healthcare workers in communication skills, and to continue advocating for both patients and doctors, we need support. Not just goodwill, we already have goodwill. We need financial support. The account details are on your screen. So if something you have heard today resonates with you, if you believe as we do that better conversations in healthcare lead to better care, please consider making a contribution before you leave this room. There's no minimum, no maximum. There is simply the question of whether you want to be part of what comes next. I hope you do. 13 years of practice, a robbery, a father who died, 4 books, 1 forum. This is what can happen when pain is not allowed to have the final word. Welcome to the inaugural Patient Doctor Forum Nigeria.
If we are wise, we know that there's always tomorrow.
Yes, you can do better. Please, a round of applause for our convener, Dr. Temitope. She has empathy. She's phenomenal. She's strong. And she's smart. She's first of all a Nigerian, then a patient, then a doctor. And when you talk about empathy, I want to say that empathy is one language that we speak so slowly, but yet is a garment that we all must wear to inspire and to heal. If we don't have empathy, then we cannot be a smart patient, we cannot be a smart doctor, and we cannot come under one forum to have a meaningful conversation. She is a prolific author par excellence. Please, a round of applause for her again.
I think that cannot even be understated. My first interaction with her, it took 90 seconds for me to see how special this initiative is. Remember, this forum is not about a debate. It's not about highlighting problems and poking at them, but it's about finding out why, what, and how we can change. Again, welcome healthcare workers, welcome non-medical personnel, and especially to our virtual audience. I think we're going to have a blast today, and we look forward to the event.
All right, thank you. Thank you so much for listening. Thank you, Dr. Oyetunji. At this point, we would like to go straight into our keynote address. And to do that, I would be inviting our own Dr. Akin Moses. And before he comes on stage, I would like to take his citation. Dr. Akin Moses is a graduate from the Ahmadu Bello University Teaching Hospital from 1981. He became a fellow of the National Postgraduate Medical College of Nigeria in 1991. He is a fellow of West African College of Physicians and from the Faculty of Family Medicine. Dr. Akin Moses joined Nigerian Army in 1980. Super. and retired voluntarily as a colonel in December 2006 after 27 years of meritorious services. He was decorated with the Forces Service, FSS, and the Meritorious Service, MSS. He is a distinguished service star. Dr. Akin joined the National Hospital February 2007 as chief consultant and head department of family medicine. He currently serves as coordinator of training in family medicine and head of department. So in order not to bore us, I would like to invite Dr. Akin Moses, who will be talking to us about the theme of today's event, Humanizing Healthcare. Please, a round of applause for Dr. Akin. Welcome, Doctor.
Wow, I don't know how to start because I'm very emotional about this day. That is understandable because most of the people involved in this project were actually my students. I feel delighted, humble, grateful, and overwhelmed with joy to have been invited to deliver this keynote address at the inaugural Patient Doctor Forum, Nigeria 2026, in the presence of a multidisciplinary audience consisting of patients, caregivers, healthcare professionals, policymakers, medical educators, regulators, and healthcare leaders who have come to explore practical ways of strengthening communication and empathy within the healthcare system. Ian McWhinney, the father of family medicine, in one of his lecture series on the 9 principles of family medicine, had this to say: if family physicians did not exist, we will have to invent them. Of course, there is no need to invent them because they exist in the composition of the Board of Trustees of this forum under the visionary leadership of Dr. Temitope Oyetunji. Please let us applaud her once more. The Board of Trustees is made up of young family physicians who have decided to come together to refocus and re-energize the prism of patient care using the power of humane and compassionate care. Thank you for your thoughtfulness. Thank you for your kind hearts. Thank you for seeing and pushing the need to make our patients happy and satisfied. Thank you for reminding us, all the health care workers seated here, that humane care is not optional, but essential, critical, and ethical. A health system can have skilled doctors and other health workers and still fail patients if it lacks compassion, respect, and accountability. A strong health system is not only measured by technology and infrastructure, but by how it treats people. Patients may forget what you said, but they will never forget how you made them feel. Patients remember how you treated them than the test and treatment that you prescribed. Listen to this. Anatoly Broyard, shortly before his death from prostate cancer, had this to say: I would not demand a lot of my doctor's time. I just wish he would brood on my situation for perhaps 5 minutes, that he will give me his whole mind just once, be bonded with me for a brief space, survey my soul as well as my flesh to get at my illness. For each man is ill in his own way. Continuation of his statement. Just as the doctor's orders blood tests and bone scans of my body, I would like my doctor to scan me to grope for my spirit as well as my prostate. Without such recognition, I am nothing but my illness. Today, we have taken time to come here, not just to explore medical practice. We are here to explore the soul of medicine. Because beyond the science, beyond the systems, beyond the resources, beyond the pressures of our profession, lies a simple but enduring truth. Healing begins when a patient feels seen, heard, and valued. Professor Eve Namisango puts it more succinctly: the architecture of healing requires more than medical intervention. The strongest medicine is often the human connection between doctor and patient. The patient-doctor relationship is a sacred place where science meets humanity. A patient is not a case file, but a human being in need of understanding. Every day, patients walk into our facilities not only with symptoms, but with a mix of need, a mix of fear, uncertainty, prevention, necessity, and most importantly, hope. Hope that someone will listen. Hope that someone will understand. Hope that someone will care. And who is that someone? You and me, every health care worker who is seated here. We have different reasons for visiting health facilities. They include emergencies and trauma, referral from other facilities, preventive care, diagnosis and clarification, psychological reassurance, management of chronic diseases, maternal and child health services, access to specialized services. But patients don't just seek treatment in hospitals, they seek relief, they seek answers, they seek safety and trust. Care providers who understand this have better patient satisfaction and health outcomes. The best treatment that gives value and happiness to a patient includes dignity and respect. Privacy and confidentiality, being listened to by the doctor and taken seriously. Simple explanation of diagnosis and treatment. Opportunity to ask questions. Guidance on what to expect when they leave your consulting room. Reassurance and empathy. Understanding their anxiety and pain. Many of us remember Michael Jackson. There used to be a singer and a songwriter who used to perform with him, Sheila Crow. She had this to say during her struggle with chronic illness: I wanted my physician to listen to my story of suffering, to recognize my plight, and to engage with me on a deep emotional level. If I had to stand on the precipice of death, then I wanted a physician who had the courage and the common decency to stand there with me. This kind of care is what mattered most to me. And that care is humane care, and that is why we're here today. The Cambridge Dictionary defines humane as showing kindness, care, and sympathy towards others, especially those who are suffering. Other definitions include marked by compassion, sympathy, or consideration for humans or animals. To be humane is to be characterized by tenderness, compassion, and sympathy for people and animals, especially the suffering or distressed. Certain factors in the doctor-patient interaction translate to humane care These include courtesy and friendliness, respect shown to patients, warmth and interest in the patient, consideration for the patient's feelings, showing concern for the patient. Humane in medicine is intimately related to the concept of the patient-physician relationship. The patient-physician relationship should model the key ethical principles of respect for persons, autonomy, beneficence, non-maleficence, and justice. Humaneness in medicine is modeled by applying the biopsychosocial approach to every patient encounter. Humane care that uses a patient-centered approach to medical care results in better health outcomes. The biomedical model of care takes the humanity out of the patient-physician encounter, where the physician focuses on the disease to the exclusion of the person who is suffering by failing to integrate the psychosocial aspects of the individual's illness experience. That which cannot be explained at the cellular or molecular level is often ignored, and the physician is often detached from the patient's overall state of health, which is influenced not only by the physical, but their mental and emotional state, as well as environmental and societal factors. Humaneness encompasses those attitudes and behaviors that emanate from a deep sensitivity and respect for others, including acceptance of their cultural, ethnic, and religious backgrounds, as well as their personal preferences. This care is patient-centered, exploring both the disease and the illness experience. Humane care seeks to understand the whole person by going beyond the individual's history and personal issues to include the context of the illness, such as family, other individuals involved, those affected by the patient's illness, and the patient's physical environment. Now listen to this. In a study conducted among some healthcare professionals to obtain required recommendations on increasing the quality of care for complex regional pain syndrome, the patients involved in this study were asked to suggest how the healthcare professionals might have more compassion for and provide humane care to them. Now, here are the suggestions of the patients. 1, always remember that the people you are caring for are humans. You have an obligation to listen to them and have compassion for them. Please believe us and take us seriously. We know our bodies. Do not forget that this affects each part of our lives. Please be kind and ask before touching. Without any doubt, humane care involves translation between health as a biomedical phenomenon and healing as a lived experience. Very quickly, let us look at the benefits of humane care. Weaver, in 2007, found that although being diagnosed with breast cancer and undergoing a mastectomy surgery is frightening and difficult, humane care helps breast cancer patients to recover physically, emotionally, and psychologically. Sharp et al. In 2016 found that without humane care, patients would not participate in their own care and would only be passive recipients of care. Again, Sharp, with some other workers, found that paying attention to patients' individual needs, establishing patient-nurse relationship by providing humane care and trying to find solutions by overcoming problems positively affect patients' experience of care. Some studies have shown that effective communication between health professionals and patients has significant effects on the clinical outcome of issues such as diabetes control, pain control, and cancer. Involving patients and their families in their care facilitates decision-making, as care goals are based on their value and preferences. This is a very important aspect of humane care. 6, improving the amount and quality of information exchanged between the physician and the patient enhances their relationship in terms of mutual respect, knowledge, trust, shared values, and perspectives about illness. This increases the accuracy of diagnosis and leads to better adherence. Promoting a patient-centered approach to medical care results in better health outcomes, counteracts professional burnout, and equips doctors to meet moral challenges not covered by biomedicine. Many complaints are not about technical errors, but about how patients were treated. Respectful communication and dignity significantly lower the risk of complaints and litigations. Humane care reduces repeat hospital visits, complications, and unnecessary investigations, saving time and resources over time. Finally, when people trust healthcare systems, they are more likely to participate in vaccination programs, screenings, and preventive care. What are the challenges to humane care? 1, personal problems. The health workers' personal problems, which may have to do with their families or even their own health, can hamper the provision of humane care to patients. 2, attitude issues. This can also pose a problem, especially when the health workers approach patients with prejudice or a judgmental attitude. 3, welfare. When health workers' welfare is affected in any way, including excess workload, stress, and burnout, or unpaid salaries, it may be difficult for them to be humane in their dealings with patients. Difficult patients. Even when the healthcare workers are willing to be humane in their dealings with patients, such resolve may be tested by difficult patients. A lack of resources or shortage of staff can also hinder the provision of humane care to patients, even where the health workers are willing. Improper use of advanced diagnostic equipment may make diagnosis and treatment of patients more impersonal. Let us look at the peculiar challenges affecting humane care in Nigeria. Humane care in Nigeria suffers because of palpable strain and stress on our health system. We have a very poor doctor-patient ratio of 1 to 9,000 in some areas, and national health budget of about 5% compared to the AU budget of 15%. Poor interpersonal treatment of pregnant women due to long waiting times, disrespectful treatment, and poor communication discourage use of services, leading to maternal mortality rates as high as 2,000 per 100,000 live births in referral facilities. Although our government is making efforts to reduce financial barriers through the NHIA, patient experience relating to delays, staff attitude, and inefficient processes affect patient satisfaction and quality of care. Humane care in a facility can be impaired when the public perception and trust in that facility is fragile based on level of competence, communication, and accountability. Humane care suffers from poor system capacity arising from poor infrastructure and limited facilities, which reduce quality of care. We must always strive to improve human care. How do we do that? Appropriate training and retraining in communication Beyond clinical skills, improve humane care and patient experience. If you don't train and retrain for humane care, the system will default to efficiency and dehumanized care without empathy, and that ultimately harm both the patients and the providers. Rewarding and effective queue management and appointment systems reduce waiting time and promotes humane care. Feedback system ensures that patients are heard, thus improving trust and outcomes. Improving leadership at various levels of healthcare that promotes humaneness, enforces standards. Ladies and gentlemen, distinguished guests, as we conclude, let us be very clear about why we are here. Medicine is not only a science, it is a human relationship and moral practice. In the midst of protocols, in the midst of pressures, in the midst of performance metrics, we must not lose what matters most. The patient is a person. We may not always cure, but we can always care. And often, it is that care expressed through empathy, respect, and presence that defines the true quality of our practice. At the end of the day, our impact will not be measured only by outcomes, but by the trust we build and the dignity we preserve. Let us therefore commit to practicing not just with competence, but with compassion and humaneness. Thank you for your patience and attention.
Please, a round of applause for our erudite doctor. A very insightful conversation, actually. And my takeaway is everyone is a human, and we need to provide humane care. For the patient who is stubborn, I think you've gotten a lot from this conversation. And for the doctors who are suffering burnout, fatigue, stress, and for the government who is supposed to provide the resources and the financial welfare for our doctors, should please do more, because most of our doctors are leaving the country. The Japa syndrome is affecting us. And today there's even more issue to that if we don't build the system. At the beginning of this conversation, I actually said that we are the system that is about to fail us. And if we don't realize now that we're all stakeholders, then we have a problem. And I think we should take seriously this forum. I think I'll take one or two goodwill message now. Okay. So we have a goodwill message from the chairman of the Dateline Health Africa, Akintayo Odutola, and he's sent us his goodwill, actually, and I'll read it. I commend and congratulate the founders and organizers of the 2026 Inaugural Patient Doctor Forum. In an environment where health misinformation is widespread, this forum is exceptionally timely. This initiative, which aims to foster effective communication between healthcare providers and consumers for improved healthcare outcomes, deserves broad stakeholders' support. I personally commend the initiative and wish the event spectacular success. Thank you so much, Dr. Akintola Odutola from Dateline Health Africa. Please, a round of applause. More goodwill will be coming, and we will continue to acknowledge the very important guest here today. Before this conversation started, all right, we'll take another goodwill message shortly by our own Dr. Oyitayo Oyetunji from the Federal Commissioner, who is Federal Commissioner at NPC or your state. Please, a round of applause for Dr. Oyetunji as he steps forward.
Thank you very much. Our dear MC, I thought I should come quickly because I can see you're having difficulty, all the titles and all of that. The real reason I'm here is not because I'm a commissioner, but because Tope is my niece. I'd like to acknowledge the guest of honor, the keynote speaker, our distinguished lecturer of the day, my dear friend and brother, the chairman of the Family Planning Association of Nigeria, and all of us who are here. Dr. Temitope Oyetunji, today, we all have acknowledged that she's a phenomenon. From the very young age that I knew her, she's always been that. She used to come first in every class she was in. And because her name is Temitope, I changed that name to Tops. She's always been on top of her game. And she's a person with unusual interests, unusual hobbies. You'll be surprised that she's a very accomplished guitarist. She plays the guitar very well. For a medical student to have time to learn to play the guitar, that's something. She used to be a blogger. I don't know if she still does it. She had a regular presentation that she used to make. And now she came up with this idea. And typical of her, she's approached it with so much passion. I'm very proud of you, Tope, that you put this together. The topic of the day is an important one. And my sincere desire is that this effort will not be in vain. As she has acknowledged and emphasized, there's a vacuum in terms of doctor-patient relationship. I've had limited experiences, beginning from my work. We did a survey at the National Population Commission, a verbal autopsy survey, to try to find out causes of under-5 mortality. We're all aware that Nigeria ranks unfortunately, very high. I think we're about the third in the world in terms of the frequency of under-5 mortality. And after the NDHS, the National Health Demographic Survey, that identified the number of persons, of households where this occurred, we did a follow-up survey to try to find out the causes of under-5 mortality, trying to discuss with caregivers, household members, what they can surmise as the causes of under-5 mortality that happened in their households. And when the report was presented at that time, under the minister, Dr. Ohaniri, I think, Osage, yes. He was taken aback by the time he went through the report. Among several other reasons that caregivers gave. One reason that stood out was that many caregivers felt that what was the point of going to the hospital? Because most times when they go, the doctors, the nurses will begin to accuse them of not doing enough. And they felt that if all I will get is accusation, what's the point? These were responses that were given by caregivers in households. There were other reasons, of course, safety, going to the hospitals at night, getting attention on time. But one that surprised the minister was that many of them felt that they will not get the right treatment. Also, my daughter is a physician. She's in Australia. She wanted to do her professional exam so she can get papers to be able to get residency and all that. And so she engaged, or she worked with a company that would do something like a pre-test for them, something like a mock before the exam. And that company did the mock exam for them, and she failed. Guess why she failed? Because she was not because she didn't show empathy in her relationship with the patient. They had real patients. The company brought real patients, and you do diagnosis, you do all of that. But coming from Nigeria, my daughter just went straight to it. What do you say they do you? And so on. And they were shocked. You're not even asking how the patient feels, what's happening at home, and so on and so forth. And at the end of the exam, they told her the reasons that you didn't show empathy. So what Tokwe is doing today is a reality. Also, my wife's sister we lost her in UCH. She was a nurse at the UCH Ibadan. She herself was a nurse in the hospital, and she felt ill. And while she was in ICU, at a point, because of all the, I don't know all the technical words, because of all the insertions and all that, she couldn't speak anymore. The best she could do was to write. And that morning, one of the things she wrote was that this nurse is a very wicked man, because all my effort to call his attention throughout the night failed. He just ignored me. That was coming from a nurse herself, a nurse of over which I've written down, I'd like to go on. We may not always be able to cure, but we can always care. We may not always be able to cure.
Is the power for the barrel
That this forum is sustained, and that thing that gave us from our watchword. That the patient will say, well, even if I wasn't cured, that doctor cared for me. Thank you very much. I'd like to acknowledge Chairman National Protection. The award that Tokwe has instituted in memory of our dad, who is the only brother I've ever had. what? I said, well, yes, that's good, but it shouldn't be a family affair. Let me ask my chairman.
Erudite professor, somebody I admire from afar. She is a professor of medicine, endocrinology, and diabetology, a director at the Center of Diabetes Studies, University of Abuja, a fellow of several prestigious awards and institutions, including the Royal College of Physicians and the American College of Endocrinology. She is a member of national and international technical working groups on non-communicable diseases and diabetes prevention in Nigeria. She is a consultant to the World Health Organization for diabetes care.
Again, I remain your co-host, Dr. Inaugural, and I'll be moderating this session. So, I would like for us to go in this order. So I'm going to call our first speaker. We'll give a little bit of a round of applause. And
quickly reduce your ties, your legs. Just go and have some extra done. And I kept having experience for 1 to 3 years. And this thing kept getting worse. And nobody appears to have an understanding of the issue. And then the thought around came when we discovered what it was, because somebody took did some special attention, and it wasn't just about that mechanical, clinical response. That interestingly, you said we shouldn't mention hospital, we shouldn't mention name. I won't mention name, I won't mention hospital. Interestingly, I've seen I do today before. And every member of my family is quite close to her now. Because when we go to the clinic now, we actually demand that we go to see her, not any other person. Because she took that extra care. Ask a lot of questions. And that was when we called to her that for 3-4 years, I never called to anybody that go for an MRI, which would have brought out what we done. And it's actually also very traumatic for one reason, where sorry I'm taking more than 2 minutes. One is very traumatic for me because it wasn't at some point, but it's not just about my back. It's not just about my spine. It's actually about everything about my life. As a development worker, I spend most of my time doing policy analysis, sitting at the computer, reading, talking with people, sitting in meetings, and everything about my life, about livelihood for me, is also tied to it. Because if I can't sit, if I can't sit at meetings, if I can't sit to read, if I can't sit at the computer to write, everything about livelihood is also tied to it. Then, the sad part of it is also that I lost attention in Abuja here, because somebody also didn't pay due attention. Says spondylitis, the person had some, and we were told it was successful. Then we found it because somebody also didn't pay due attention.
That's quite unfortunate, sir. But it's a really interesting perspective that we can all see a bit more. And I love how we're already starting to go into this. We're going to hear also from the medical point of view how sometimes what brings this status where a patient leaves feeling unhappy, not taken care of. With just less than 90 seconds, I would like to hear if there's any other story or anecdote you'd like to give, sir.
Okay. My case, let me start by talking about a case where I almost brought down a major hospital in this town. I could be very crazy sometimes. But what made me not bring it down was because the MD of that hospital at that time was a doctor that had this relationship with me. The very first time I walked into his office, it takes a smile, just like what a commissioner said, about how you ask about the person, how you talk to the person. And I was just like, because of my media background, I just told the doctor, I said, you need to be on air, and I arranged him to feature on several programs. So luckily, he became the MD of that hospital. This doctor was not paying attention to the case of my daughter. She was 4 years old and gave some really crazy prescriptions like that and diagnosis. But we thank God she was saved. And so I got in there and found out all this. The doctor came to the ward, knelt down before me, begging, because I would have turned down the whole place and he would have lost his license, begging. And the hospital was crazy. I just called the MD and immediately activated oxygen and everything like that. Now, but what did I do? Because of the kind of relationship, and I had loads of other doctor friends there. So I was surprised that not one of them even handled my daughter then. And I told them, I said, don't fire this guy. Rather, send him for further training. A few months later, I came and I asked of the guy in the hospital, and from one of my other friends who is a doctor there, and they said, that guy has been on some kind of training since he doesn't attend to patients like that. And I told the guy didn't know what happened. I told him what happened. I said, no wonder. You get it? Now, when you just are patient a little bit, listen to the patient. Listen to where they're coming from. They probably have seen one other doctor also. Don't just say, and then get out of the place. There might be some story behind the situation that someone could use. And once that happens, you find out that a lot of, I keep saying it's not the medical issues that kill people. It's that lack of communication or relationship that kills people.
Thank you so much, sir. That's really, really insightful. And I love the next person that I would like to ask for an anecdote, Mrs. Victoria, who is kind of like one of those unique positions where you are between being on the patient side and also being on part of the healthcare provider, especially working as a health administrator. Do you have something to add, ma'am?
Okay.
On your personal note?
Okay. My personal experience was this fateful day. I won't mention hospital anyway because I work in a hospital. So there was this distressed guest that was brought in as an emergency, and as nurses were attending to the patient, they call off an intelligent doctor, a competent doctor, a skilled doctor came in, and sorry, I was get instead of patient. Please permit me.
Okay, ma'am.
Because of where I worked. And was not, the guest is in distress. Let me get me an oxygen so that I can quickly attend to the patient. And by the time the doctor gets to the oxygen to on the valve, the oxygen was empty. And the doctor looked down, get me more oxygen, go to the oxygen store, get me another oxygen. There was no oxygen in the whole hospital. And this guest is in a distress. The doctor was confused. The doctor was helpless. The patient in distress is in front of him, but he could not do anything. In that way, it makes me to think that sometimes people are helpless, not because they don't have the competence to attend to the patient, but because the structure has failed doctor. That's why. And that also taught me that we can do better by providing the necessary equipment for the doctors. Because the doctors are not seeing the institution, the doctor to ask, doctor, what is going on about my relative? But the doctor was helpless. He could not do anything. So sad.
Such a unique perspective now that we can see that, well, in one hand, sometimes it can be some lack of attentiveness. And other times we can see that institutional defects can really affect how provision of healthcare is. I want to ask Dr. Abusa, from your own perspective, what do you think has uniquely affected, especially the healthcare dynamics of a provider and a patient, from your own perspective?
Sorry, me? Oh, okay. Before I speak to that the dynamics, I would want to comment very briefly on some of the points that have been raised by the panelists. And some of the lessons that I'm picking from this interaction, and it's a learning process, basically, is that in the case of the spondylotic patient, what clinched, what made a difference, what provided the patient satisfaction was just an extra step to make a diagnosis using an investigation that you felt added value. In the next person, of course, I'm sure your daughter is much better now. We're happy to celebrate that. And we're also happy that the hospital was not taken out. But more importantly is that one of the things that threw you off was the dismissive nature of care. That dismissive nature really threw you off. That lack of communication and an apparent failure to listen was unacceptable to you. And definitely, when that was fairly resolved based on the background relationship and institutional relationship with the MD, you were able to mitigate the situation. And from the hospital administrator, of course, she pointed out the defect in the system. So that tells you that in providing humanized care, if you'd listen very carefully to the lecture of my mentor, Dr. Akin Moses, he basically situated it. And but to build on that, we need to place it against a certain context. The nation, the government, the key stakeholders have a role to play. The hospital administrator has a role to play. And of course, the doctor-patient structure too has a role to play. But if you place that contextually against the fact that we're a country of 240 million people, WHO recommends 1 doctor to 600 patients. That means we need today, as we speak, 400,000 doctors, as we speak. But we have today, the MDCN says 55,000. A study by the Professor Sibanjo, His Excellency's committee, came up with an active 19,000 or so, thereabout. And some of us feel maybe let us put it at 40,000. That means we are 10% of the doctors we need as we speak right now. Now, when you look at the distribution of those doctors, a state like maybe Enugu has 1 doctor for 300 patients. But you go to certain regions, you have 1 doctor to 100,000 patients. And I'm not kidding. That is a problem with human resource. Dr. Akin Moses pointed out the issues with financing. Financing is a huge gap. We only have just about 20 million Nigerians covered by NHIS. That's less than 10%, 8.5% thereabout. China has 99%. Rwanda, Kigali has roughly about 85%. So we do not have the framework for universal health coverage. So it means that 90% of our population are exposed to catastrophic health expenses. That is a challenge on its own. The other issues, obviously, is out-of-pocket expenditures and all the other issues that come up with it. Structure-wise, how many structures do we have? On paper, we have 30,000 primary health care centers. That is a challenge. Only about 8,500 have received some level of intervention in the last couple of... we can go on and on and on. So we do have a health system that is challenged. We do have a health system that some people feel is broken. Now, within that framework, of course, the government has taken significant effort. But from all of this, one thing comes out is that when you have a patient in front of you, has the hospital administrator provided oxygen? Is the doctor trained to offer humanized care? And within the curriculum, due respect to every other specialist, but within the curriculum of the family physicians, our mentors have created a component of patient-centered care that is ingrained in your DNA. One of the strategies that we must start considering is what Cuba has done. As you graduate, before you go on to do this kind of specialization, you must go on to do specialize in family medicine. That ingrains in you empathy, compassion, evidence-based care. And then you can go on to subspecialize. But when you have prepared your doctor, you must also prepare the hospital. There must be drugs, the structures must be there, SOPs must be in place, oxygen. The ICU must be working, the theaters and the consumables must be in place. And obviously, we must increase funding from 5% gross national budget to the recommendations by the AU president, which is 15%.
Thank you, sir. I think one thing that is very apparent is I love how we objectively even highlight some of the factors affecting healthcare. And we can see that healthcare provision today carries immense burden and pressure from, like you say, anxious patients, long queues, exhausted doctors, just system that seems broken down. I just want to ask one follow-up question I want you to touch briefly on, sir. Do you think, or does good communication skills play a role as a doctor in helping to navigate the situations, and how we, as healthcare practitioners, can help work and sieve through these things? And do you think doctors receive sufficient training for it? You mentioned family physicians, but we also have a plethora of other specialties.
Communication is everything. So you must listen to your patients. Some patients have been everywhere. They just want to feel heard, and people have made that allusion. And so one of the trainings we get as family physicians is that the first few moments, you just sit down quiet and listen to this patient talk. Sometimes we feel that the 6 minutes, 17 minutes, 18 minutes, depending on where you are working and what is given to you, is not enough for you to consult. But most patients, 90% of patients, cannot talk for more than 3-4 minutes. And they will basically, and you would see exactly what they want. What is more important to you may not be as important to them. Somebody comes to the hospital, he has cancer, but that's not his problem. We had a patient one time, and we're trying to investigate him for cancer. And he was worried about his labs coming back and whether he was HIV positive or not. So you need to be able to listen. And the most critical component of listening, of communication, on the part of, is to listen. But very importantly, when you communicate, listening contributes just about 8%. Body language contributes even much more, 55%. And just the tone, the para-language, contributes about 35%. So that really tells you that 8% is just what you hear. You need to watch how the body language of your patients. You need to see how their tone is. So that's critical, absolutely. So, and in terms of training, we do not get enough training. The framework for training, medical training in Africa, is frameworked on a biomedical structure, which is the traditional training. Meaning that diseases are caused by organisms. Yes. But, as pointed out by Dr. Akin Moses, there is a biomedical, biopsychosocial component, which tells you about the biological causes, which are organisms and pathological processes, the psychological causes, the emotional state of the patient, and the social structure, family dynamics, and all of those things. So we do need to deepen training in these aspects. And in deepening training in these aspects, there are different platforms. One of the things we should push for is that I think every medical practitioner should probably consider a diploma in family medicine, if you're not specializing in family medicine. It has documented and it has been shown to be a complete disruptor in patient practice. So we have a diploma in family medicine training, but guess what? Every doctor, general physician, specialist who applied for that program, we've had professors in medicine and surgery go on to do that, and it completely changed their scope.
I think one thing I love about what you said, sir, is when these things are being ingrained into all specialties, we can definitely see how, especially improving communication can help better healthcare outcome, even in a society like ours where there are so many factors that affect it. Thank you again, sir. A round of applause for that, sir. Barrister Owa, In your years of medical legal practice, I'm sure you've seen many breakdowns and misunderstanding turn into disputes and litigation. Just one or two. What do you think are some of the most common cases that you see, sir?
Okay, thank you so much. First of all, let me congratulate and appreciate the conveners of this forum. It's timely, it's important. There are several causes for medical legal conflicts and crises. But one, I want to say that the speaker, I listened to the speaker, and a number of the things that has been said is communication. I've had several scenarios. I'm handling a number in court. I've read a number in our law books. But litigation is the terminal stage of a conflict that starts often at the registry, sometimes even at the OPD, what we call the outpatient department. The innuendos, the way the patient is treated, and then the supposed clinical complaint that really took you to the lawyer's office. I actually realized after looking through every case, it's not really the issue itself. When a mother is ecstatic and raving and shouting about the mistreatment of an infant child, is it possible that the conflict is not really about the handling, the medical or clinical handling of that child, but about how the people at the cards register treated them, because we talked to them, and the dissatisfaction generally, and the inhumaneness that
that is working on his 50th, 60th patient that day and is not smiling, or a system that is somewhat designed to work against you. Let me come back to you, Mr. Leonard. You've worked in the media, and especially in today's day and age, where we've seen how media shapes constructs, especially
It's the same thing for the media. Doing development media is a very difficult thing. Now I've worked with Mr. Tunde here for over 2 decades. Nigeria had one of the best communication strategy for HIV. And it's that communication done with the media that stabilized HIV in Nigeria. It's not the medical whatever. Professor Shotimei was well respected worldwide because of that. Personally, I, sitting down here, won Best HIV Sport Award in 2006 worldwide. We produced a radio show called Flavor. It was aired by all the media organizations. We trained media stations, producers, how to produce things like that. And that is what led to it massively. We have peaceful, in quotes, elections in Nigeria today with Mr. Tunde, actually, and all that worked on the No Sidonlu campaign, using the media, training them. Now, in this medical space, the problem is that the media is there, they are facing their own headache. The medical people are facing their own headache, and that's my issue with the NMAs of this world. And that is why the moment I saw the poster of this activity, I just reached out immediately. She's been on several media organizations. There are media organizations. She's been on network and all that. Because someone was able to pitch it to them, and someone was able to build their capacity to make them know how to key into issues like this. For instance, if you don't do that, all they will see is where they'll get the money to buy diesel, and they'll go for the politics and all that. Thank God we have a commissioner here. The major morning shows of stations would rather go for commercials that will give them money. But people forget. Today, the refineries we are talking about, the diesel we are talking about, the gas that is making us not to have electricity and all that, all sectors are run by human beings. And when they can't get that health care, when the communication in the health system has that breakdown and people can't get succor, how can they provide these services? So, what I would encourage us to do is this. The media on its own, nobody trains the media nowadays. In BBC Media Action then, we're responsible for 80% of the media training in this country. The organization is not like that since Brexit anymore. Who does it? How many ministries have voted funds to train the media on how to handle these kind of critical issues? You don't find it anywhere, even in the presidency. This will be on network, and people are listening. So that is what we need to do. Invest in building the capacity of the media so they know that how they can relate these issues well. If they don't tell the stories well, they'll just come and talk just one word wrong. They'll say, okay, this event happened and that's all. What is the event about? Nobody knows. They might even misquote something. And just one word that goes wrong on air, someone is dead somewhere. But if we build their capacity, make them know how to understand this terminology, how to understand these issues, and how to put it out well. I'm telling you, just with one major campaign, and I believe this forum has started it, and we're going to see it going forward, just with one major campaign like this, and the media putting out the right stories, you're going to be surprised how a lot of conflict, communication conflict in the medical sector in hospitals between doctor patients will be solved.
Thank
but
you,
we need
sir.
to build their capacity.
Thank you so much. I think you touched on policies again and structures being built. So I want to come back to Mr. Tunde, especially because both of you have worked together. We've seen now that good intentions is not enough to save a life. Whether it be from, and we talked of media now, sometimes a lot of our media these days are not even trained people. Someone with a smartphone and Twitter can shake the world with a viral tweet. I want to ask, especially in our society where even before a patient goes to the hospital, they're already anxious. I've met someone that I asked why the person went to a pharmacy rather than to see a doctor. I'm like, you know a pharmacist cannot properly deduce a treatment plan for you. And the person responded, so I'll go and wait for 3 hours in the hospital. Or is it that place, that hospital used to kill people? Like before they even get there, there is already the idea of that. I want to ask, sir, from your perspective of policies and spaces, knowing it's not maliciousness, where does the deeper failure lie, sir?
Okay, thanks. I mean, I'm suspecting that she wants to chase us out of here. So I'm going to combine a lot of things in responding to that. Because I've also listened to us, and I listened to you, sir, when you were talking about, particularly, let me start from the case of the spondylitis. I think it's not just that there was that extra test. I think that wasn't the issue. I think the issue is that somebody did not pay attention. That's number one. And it still comes back to the issue of now regulatory framework that we have. And then we can also look at the issue of weak regulation within the sector, within the medical practice sector. This is not about the individual doctor now. Because the system is also already skilled in such a way that that medical doctor I met was not responsible because of the system within that person that practices. When I spoke about regulatory framework, I was stunned. I was surprised. About 15 years ago, I got into a clinic in Abuja, and a medical doctor was agonizing about something that happened to his own relation. That a relation of his lost a kid because some other medical doctors did not pay enough attention. And he now said that, look, I'm sitting here and giving other patients enough time. And I go home feeling comfortable that I've seen 2-3 patients. And that the problem is not also with that medical doctor who did not pay attention. But because the system is already putting him under pressure, not to pay attention because he or she is paid according to the number of patients they see. Who pays attention? What regulatory framework is there? Who is doing the monitoring? Who is asking questions? That's how are medical doctors paid? How are nurses paid? Where a medical doctor is paid according to the number of patients they see in a day. That doctor, he or she has a family to feed. And when that person's income is determined by the number of patients he or she sees, that means that person is not likely to pay enough attention to the patient's issue. That's where I'm talking about regulatory framework.
Yes, sir.
And the monitoring system. Then apart from that, there's also, because I will also link it to what you said, sir, about Cuba. That system that you have in place is also because the country also approaches even medical practice from the right perspective. What I would call right-based perspective. It's about that citizens have right to proper health care. And that is why it is deemed important that every medical doctor, after qualifying, must also go for that extra training in family health care. I mean, and that's the problem where we have in Nigeria, really. When you talk about where the gap is, where the challenges. Sorry, I'm making it a staccato because she's going to chase her out. Okay. Because when you look at
a few more points.
Yeah, let me quickly just wrap up.
Sir.
On
Thank
this.
you, sir.
I've spoken about regulatory framework. I've spoken about the issue of right-based approach to healthcare. And you look at what we have in place. Every time I listen to the news, and we are talking about improving our healthcare, and I stand to be corrected. 90% of time, what I hear about improving on our tertiary healthcare system. I work in the development sector, and what we spend money on is what government has already failed in doing, paying attention to. And you can correct me, sir. We don't have enough primary healthcare system. What we spend money on is tertiary healthcare system, which is attending to the problem, the challenges of the elites. And this is also where part of our policy system, policy environment also stays. And because I also, sorry, I'm a voluminous speaker, but I will
Thank you, sir. Okay, let me just chime in here and bring this home. I think this is what the Patient-Doctor Forum is about. We are not here to debate, but to create dialogue. And we have seen from different faces what this conversation can do. So we start here. It starts with us. It starts with conversations of how we can make it better, from communication to perspective of caregivers and patients and even physicians. I imagine that we can go on for hours because there's so much. And a lot of us as Nigerians, we are burning with passion on this matter. But because of time, let me just say, I know we'll still have opportunity to ask questions and our panelists will contribute, but we'll be liking to conclude this session now.
Okay, just to, I can see Dr. Iseko here. He's involved very seriously in the Guild of Medical Directors. and is obviously doing a lot of work in cardiology. We are proud of. My boss is here, Dr. Akim Moses. So in this room, and Professor is here, fantastic work internationally. In this room, and we now have the PDF forum, which even if it's the acronym is Patient Doctor Forum, it's an entry into the health space. Sometimes it's the nurse that has just annoyed the patient and is transferring it and is saying it's the doctor. We need to look at some of these things.
Yes.
But more importantly, the Society of Family Physicians, I am sure, can provide online training for all the staffs, doctors, nurses, within every hospital in Nigeria, not for free. I know Dr. Eseko can arrange that. So you should talk to your guys, the directors of all hospitals, that we need to organize. Let it be that this is just maybe the first scratch. Let's do training for every healthcare worker working in the private sector. You account for 70% of the health sector. So let's do training. Let's put it
Thank
together.
You, sir. So this is a call out to both our virtual and in-house audience. In any way you can contribute to the initiative, we look forward to you meeting us at the front desk or meeting some of the partners here. Thank you so much for your time, sir. It's been a pleasure. And you may have a seat, sir. Thank you, sir.
Please, a round of applause for the panelists. The conversation has been highly impactful and insightful. I enjoyed it all the way. So at this point, we're going to entertain 2 questions. Because of time, please, if you have a question, just raise up your hands and then we'll pass the microphone to you. Okay. Any other person so that we can just simultaneously take the questions?
Should I go? Should I ask my question?
All right, go ahead.
Okay, thank you very much to the panelists for your very insightful views and experiences. My question is just related to training around communication, and I think doing general practice after qualification is a very, very good idea. But my question really is whether or not actually taking it a step back and incorporating communication skills in medical school and the medical curriculum might be something to think about and add, whether or not that might be another avenue in just building that foundation of communication and empathy.
Okay, good day, everyone. I don't have a question, it's just more of a comment. With regards the communication between doctors and patients, granted, a major problem is the shortage of doctors in the country. But then the question is, with the doctors you do have, how are you fostering this communication? And it's never going to work when you have doctors, like that was mentioned, that come to work frustrated. It can be done about the patient load, but you can improve the welfare of the doctors that see these patients. Not just the doctors, but the nurses too. You can't expect someone coming to work, let's say working in a tertiary institution that has a huge workload of patients, and their work shift is insane, their pay is not good, let's say no accommodation is provided, and you expect them to see the amount of patients and be willing to be communicative and pay proper attention to each patient when they do see them. It's not going to work. So those are things we do need to consider.
I'm sure we've gotten the question. So the panelists had already left, but I'm sure they can respond very quickly to Just very quickly. Okay, they're all coming. Thank you so very much. At this point, I would like to acknowledge the presence of Dr. Abubakar Salami, who is GMD of the Dhabi and Partners Nigeria Limited, ably represented by Mr. Emmanuel Odiase. Please, a round of applause. So very quickly, I would like to bring my mentor back, Professor Anu Felicia, who is a professor of medicine and endocrinology and diabetology, an expert of diabetes who has run several fellowships of several institutions, including the college, Yeah. Please, a round of applause for me. Yes. And she is the director of the Center of Diabetes, University of Abuja. And by the way, it's named after her. She is my mentor in the writer space, a multiple award winner. Thank you so much, Professor.
Good morning. This is not working. I prefer to hold if it's working. Because I've been moving around. I hope it will work. I have to be moving around. So if it works, you can bring it up. Okay. Good morning, everyone. I'd like to acknowledge the convener of this meeting for inviting me to give this brief talk. I also want to acknowledge the chair of this meeting, the DG of National Population Commission, and the commissioner, who is the convener's uncle. All other protocols I adopt. Thank you very much. I'm meant to talk about, I'm meant to talk about shared responsibility in achieving quality health care. I want to say something before I start my presentation formally. It is a privilege for me to be a doctor. That's how I see it. To the glory of God, this is my 40th year as a doctor. So I've seen patients for 4 decades. You can imagine how much I have seen. And why do I say it's a privilege? Because God has considered me a noble instrument to partner with him to preserve life. And again, medicine is unique. Why is it unique? It's not because doctors are the, most intelligent human beings in this world. The job is unique because they deal with a unique object. That's what makes the job unique. And what is this unique object? This object is unique because it has a body, a spirit, and a soul. That's why the object is unique, and that's what makes our job unique. And therefore, I owe the creator of the subject a responsibility. If this object is before me, and I recognize what I've enumerated, then the creator of this object will score me good. But if I don't, by the way I handle this subject, then I get what I deserve. The other face to it is, if I recognize that I am partnering with God to preserve life, then I can also depend on him to give me the wisdom to do what is right for that object before me. So this is how I see myself as a doctor. And I'm a teacher in a medical school. I have trained people who are professors like me now, and so I try to make sure that I inculcate this. And so I'm going to go through some little introduction, what patient-centered care is, the core concepts of modern healthcare, healthcare providers' responsibility, institution and management responsibility, government and policy makers' role, patients' responsibility, standard diabetes care as a model, and framework for engagement, and then conclusion. Next slide. Okay. So what is quality healthcare? That is care that is safe, that is effective, that is patient-centered, that is timely, efficient, and equitable. What's quality in healthcare? What do we mean when we're talking? Because all we are talking about here is upskilling the quality of care that we give human beings. This means doing the right thing at the right time. When I tell my residents, doctors with me, that when we delay in attending to patient, that patient may not wait for our timing. By the time we get there, that patient has gone. So patients can't wait for our timing. So at the right time, in the right way, how you deliver it. Part of what the conversation here is how. And then for the right person, who are we delivering this care to and having best possible results? That's what quality in healthcare is all about. So what is patient-centered care? We've heard that word severally this morning. It's care that is respectful of and responsive to individual patient preferences, needs, and values, ensuring patients' values guide all decisions and is an essential foundation for quality and patient safety. Next one. What patients want really from healthcare providers? What do they want? Very simple. Patients want healthcare providers to be good communicators. We've been talking about it since. Good at listening. Good at explaining things. Using plain everyday language. I agree, that's one of our problems. But in diabetes care, we try to make sure that we come down to the level of the patient. Speak the language that patient will understand. If it is pidgin the patient will understand, speak it. Don't use medical jargons that you use in classroom or with your colleagues. No, you put the patient off actually. Having a good clinic and bedside manner. There is what we call clinic manner, bedside manner. In fact, in our exams, we can fail a student or a resident for having bad bedside manners. He would have done well in every other thing, but with that, we can actually fail that student, he'll come back. In fact, in my unit, if a patient has a drip and the hand is swollen, we know how painful it is. So if a house officer or, just goes and lifts the hand and the patient screams, that house officer can have an extension from me because of that. Adopt a non-judgmental attitude. Okay? You listen. For example, my diabetes patients come, they've not done what they are supposed to do. Blood sugar, they come with very high blood sugars, and they're already feeling guilty before they come to me. So when they come to me, I tell them, don't worry, we are all human beings. We can make errors, And sometimes, even though you have diabetes, that does not mean you will enjoy life. No problem. Let's see what we can do to make sure that these values come down. Then that calms the patient down, and we're able to converse at the same level. No fear of being criticized. We shouldn't criticize the patient no matter what the patient says. Patients want better care. They want lower costs and better health outcomes. That's what they want. What patient-centered care is not. It is not compliance. Oh, I give you instructions and you comply with them. No. Improve self-management and healthy behaviors. It takes a lot. I don't know if there are psychologists here. For behavior change is not very easy. So we have to give them time. It's not education campaigns. It's not provision of financial rewards. It's not doing what is best for the patient, because what is best for the patient, what you think may not be what, Dr. Buta gave an example. That somebody who they are investigating for cancer, his own concern was HIV. And then designing patient-centered care without the patient. So patient-centered care is not any of this. Patient-centered outcomes. They want outcomes that matter to these patients include better quality of life. Mobility, they want to be able to move around. Ability to carry out tasks, ability to focus. Side effects, risk of treatment. They don't want so you're treating them for something and then the side effect is now the one that's not allowing them to function. They don't want symptoms. They don't want pain. And then they want to survive. Everybody loves life. They want to live. And then you must consider that outcomes might be different for each patient. So it's not one cap fits all. But achieving quality healthcare is not the sole burden of doctors or hospitals. It requires a genuine partnership. The core concepts of modern healthcare. There is a paradigm shift. Moving from a paternalistic model to a collaborative partnership model. So there has been a shift from the old paradigm to a new one. Interconnected web. It is an ecosystem where care is co-produced by everyone involved. Optimal outcomes depend on continuous collaboration between patients, providers, facilities, and policymakers. The old paradigm, that's the provider, the expert, the traditional primary care approach. This approach is health behavior change. To health behavior change is a technique called advice giving. The provider is seen as the professional expert who knows what is best for the patient. This approach takes for granted that patients should change their behavior, whether they like it or not. And that they want to change. It's taking things for granted. It's being presumptuous. Their health and their prescribed regimens are major priorities for them. We are just being presumptuous if you assume this. And this is the old paradigm. The new paradigm is the interprofessional collaborative team approach. That is, I am an expert about me. The patient is the expert about him or her. Proactive in prevention versus reactive to disabilities incurred as a result of diabetes, for example, or any other disease. So this is partnership, collaborative work together. Healthcare providers' responsibility. So we said it's the shared responsibility. Clinical competence, maintaining up-to-date medical knowledge, evidence-based practices, and continuous learning, like we've been saying. Communication and empathy. Actively listening to patients and clearly communicating risks, benefits, and alternative treatment protocols. Team collaboration, working cohesively with nurses, pharmacists, and every other person involved. And then patient advocacy, safeguarding patients' rights. They have rights, their dignity, preserving the human dignity in them, very important, even though they are called patients, and advocating for the best possible clinical outcomes. Institution management responsibility, system design, we've been talking about it. Creating physical environments and workflows that prioritize patient safety and minimize errors. resource allocation, providing adequate staffing, advanced medical technologies, and continuous training for staff. Culture of safety, fostering a workplace environment where staff feel empowered to report errors and suggest improvements without fear of punishment. And then quality improvement, very important. Now, healthcare providers and institutions, clinical excellence, adhering strictly to evidence-based practices, and empathy and maintenance of privacy in hospitals and confidentiality of all information and records of patients. We are meant to, observe confidentiality as far as the patient's records are concerned. And then hospital resources such as patients' representative and ethic committees that will assist patients to resolve problems. The lawyer said that actually much of the issue is communication, and truly, if good communication takes place, it won't even get to you. Okay, government and policymakers' role, establishing standards. I think some of government's responsibility had been mentioned, enforcing clinical governance and accreditation frameworks, resource allocation. This one is a very serious problem because we know what the economic situation is in Nigeria and all that right now, and those suffering from chronic disease is a very big issue. Patients' protections, defining and safeguarding their legal rights and medical standards. So, patients' responsibility. They are not free from this, even though they are patients. The health literacy, proactively seeking and understanding medical information to make informed decisions. So they need to empower themselves as well. Yes, it's our responsibility to empower them to some extent, but they also have that responsibility. Accurate information, providing honest and complete medical histories, current medications. Sometimes patients mislead us. They tell us lies. They don't say the truth. And whatever they say is what guides what we do. So sometimes they mislead us. Shared decision making, weighing treatment options, risk and benefits in collaboration with the provider. Active participation, engaging as a co-producer of care, asking clearing questions, and participating in shared decision making. Accountability and self-care, following prescribed treatment plans, managing chronic conditions proactively, and reporting changes in health. Feedback, of course, giving feedback to the doctor, whether it's positive or negative, and then considerate of the rights, too, of the healthcare provider. We also have rights that are to be. Okay, so standard diabetes care is a model of patient-centered care. There's what we call diabetes education, empowering the patient to be in charge of the disease rather than the other way around. And it is more important than us prescribing drugs or insulin. So education is a fundamental human right. Diabetes education is the key without which doors of good self-care cannot open and can make the difference between life and death. And this is, the multidisciplinary team approach we have in diabetes care, and you can see that the patient is in the center. The patient, even though it's a multidisciplinary team care, the most important member of that team is the patient, because we must empower that patient to be in charge and in control. This is just an example of what we do in diabetes care. And if you see this, Benjamin Franklin said, "Tell me and I'll forget. Teach me, I will remember. But if you involve me, then I will learn to be my own doctor to some extent." So pillars of collaborative quality improvement, safety, minimizing the risk and harm and medical errors, effectiveness, providing services based on scientific knowledge to all who could benefit, and patient-centeredness, breaking down barriers, communication gaps. Unaligned expectations lead to medical errors. And what can we do about that? Shared care plans and team training. Limited resources. Scarcity can hinder access. I mean, we all know that because, like we have said earlier, as far as the health insurance is concerned. And then health literacy, very important. Many Nigerians are very ignorant when it comes to this, the issue of health literacy. Well, I don't want to bore you with it, but this is a framework for engagement, okay? So these are also some of the improvement initiatives that we can take two. And what are the benefits of shared success? Better clinical outcomes, higher patient satisfaction, and efficient systems. Ways to improve funding for health in our setting is a very critical issue in our setting. We have a big challenge now with diabetes care because the medication they used to buy maybe 5,000 per month or something is about 30,000 now, 40,000 per month. And how many Nigerians can? Many of them send us messages. I'm sorry, we can no longer come for follow-up because we don't even have the transport fare. So we are seeing a lot of complications of diabetes right now because of that. And so the National Health Insurance Scheme, we need to improve, we need to step up, and then we need to look at community-based health insurance. We need to look at faith-based health insurance, and of course, philanthropy in health. We don't do much of that in this country, but I think we need to begin to look at it. Self-assessment. Are you ready to change? I'm asking those listening to me. Which areas are we going to improve? And then experts and best practices that we need to remember. Now, my conclusion is quality healthcare is not the sole burden of doctors and nurses. It requires a symbiotic relationship where policymakers and patients engage fully. The policymakers build the system, providers deliver the expertise in the right environment that has been provided for them, and then patients engage fully. There is a call to action. Let us commit to building stronger patient-partnered health systems together. It is a privilege to care for the vulnerable. We deal with an object that has a body, a spirit, and a soul. We must be very mindful of this. Now, in the University of Abuja, we identified a gap in diabetes care in this country. And that gap is that we don't have certified diabetes educators. And so I felt that I had the responsibility to bridge this gap. So I worked with the university management and we started a master's program in diabetes education in Nigeria. University of Abuja is the only university doing this right now in this country. Thank you very much.
Thank you so much, Professor. Please, a round of applause. And that center is named after her. Please, a round of applause for her. Thank you, ma'am. While Professor was delivering her distinguished address, and I thought that a lot of lapses that we are experiencing in Nigeria needs to be filled up very, very quickly. I'd like to acknowledge the presence of Mrs. Oyekachi Maxwell, the Executive Director of Everright Healthcare Foundation. Please, a round of applause for her. I'd like to acknowledge Ms. Hawa Sidi Aliu, who is the founder of Adams Pages and a mental health advocate. Please, a round of applause for her. Distinguished ladies and gentlemen, patients, doctors here present, and all our experts in the house, we're going to the agenda, one that is very dear to me. And by way of doing that, it is the unveiling of the book by our author, a prolific author. And to do that, I would like to introduce myself again. My name is Salamatu Sule. I'm a book reviewer, a poet, and a literary agent. That means I command the book ecosystem. And when we write books, we do not write it for it to adorn our shelves, because it's not for cobwebs to read. It is for us to read. It is for us to pass the torch of that intellectual content to members of the reading public and as well as students within our school system. Okay, I would like to now call on Dr. Zuliat Sani to please come forward to help us to do this wonderful unveiling. And I would like to call on the book unveiler, Dr. Oji Ejike, to please do us the honor of coming forward. And as Dr. Ejike is coming, I would like to invite all of our distinguished guests here at the high table to please also come forward to help us unveil this remarkable book. We have 3 titles here: The Smart Patient, The Smart Doctor, and The Smart Parent. And I know the next one Dr. Oyetuji will be writing will be The Smart Communicator, because that is one of the reasons why we are here today. Can we also have the author? Our book unveiler, please. Author, please. Where's Dr. Zuliat? Please, our very distinguished guests, please kindly help us come forward and help Dr. Oyetuji to do this honor.
Okay. Good afternoon, everyone. Permit me to align with the already established protocol. So it is an honor to be here today to do the unveiling of 3 magnificent books. The Smart Doctor, The Smart Patient, and then The Smart Parent. So just a summary of the book. The Smart Parent, this book started with The Smart Patient. So it's just a practical guide for patients to equip you with practical questions, to prepare for consultation, and then to be able to navigate the healthcare system. Then the Smart Parent as well is a practical guide for new parents. We all acknowledge that postpartum period is a very difficult period for parents. So it equips them with identifying common things they see in their newborn, what to panic, what to do, the next things to do, when to go to the hospital, and some of the things you can do at home. Then the Smart Doctor, it equips doctor with communication skills, breaking bad news. All the books are loaded because I've read all of them. So it will be it's a great honor for me to be able to introduce the convener in unveiling these books. Thank you very much.
Thank you very much, Dr. Zuliat. So, Dr. HK, over to you, sir.
Please, may we give them a good round of applause, all the panelists. But I think this is a standing ovation I need now to this young lady for bringing us here and then speaking to what is at her. Let's give her a good round of applause. Okay, before we open up the book for us to see, please sit down. I would like to say a few words. This is my 46th year of being a physician. And I will say that in the last 3 decades, I haven't been in the clinics or in the clinic rooms. I've been more in the development sector. So when my good brother and friend told me about this, I was supposed to be at our synod today to listen to do the bishop's charge. I told my wife, you go for that one, now this one they come for. The reason is that not just because Oyetunde is such a dear friend and brother who is passionate about Nigeria, but also for me, this also keys to what I think is important. I hear people saying communication, a lot of communication, but it's important to always qualify empathetic communication. That is the key. And the 6 key elements of quality of care, empathetic communication. That's what brings out everything. And then if you look at the training of doctors, there is an intentionality in the training of a doctor to see the patient as a whole, not just the patient, what he or she came for. When you look at how patients are clocked, the presenting complaints, Abi, that's the first thing. Then you start looking at social history, medical history, all those things are trying to make the physician know that that patient is complaining of headache. Maybe the real thing is somewhere else. But you must, first of all, empathetically listen and make your diagnosis at the end of the day. So thank you for bringing that up. I think that is the most important thing, and that will be the message. For me, remember when I introduced, they say the convener 5 million women. This is my constituency. I don't know about these guys. Now, the reason is that whatever information you want to give to the world, give it to them. They give to their spouses, they give to their children, they give to their siblings, and then women know how to organize in groups. So for me, not just unveiling this book, I'm going to help you make sure it goes into those trainings.
Please, a round of applause.
And I can tell you, I'm not boasting. He knows I have a lot of convening power, especially with the Federal Ministry of Health. I need to work with you to go to the Federal Ministry of Health. I'm surprised they didn't invite any of the directors. They were invited. I wish you told me. I would have made sure they were here. Because in the past 6 months, I've spent about 4 weeks separately, not just being a consultant, reviewing some health policies, because I feel the problem we have is in the policies, and then also making sure those policies are used. 2 weeks ago, I was in Kano. I was in Kefi to review the health promotion strategic communication. This is part of it. Tomorrow, I'm going to Kano. We are doing the final validation of the permanent methods for family planning. The upper week, I'm going back to Lagos again to finalize the strategic communication plan for the health promotion. This book, or books, is it one book now? 3 books, isn't it? They are supposed to be in those conversations. So ladies and gentlemen, may we put our hands on Bill, all of us, Chair.
Yes, Mr. Ware, kindly, yeah. Please, a round of applause. Can you see how beautiful the books are?
Let's take one copy each.
The smart patients, the smart doctor, and the smart parents. Please, can we all have a copy for a beautiful photograph? And then we can get goodwill support.
Okay.
Because I want all of these books out of this shelf by the time I'm done.
Okay, we'll come over there.
Please, can we?
Yes.
Yeah. Please, can we? So that the camera can have them.
Okay.
Really nice. So sorry.
Thank you very much.
Yes. This is what we call trilogy in literature,
Come here.
where each of the books actually also sync with the other one. To better understand one is to understand all of it. So, ladies and gentlemen, we're presenting these 3 very important communication books as well as collaborative books to members of the reading public, the patient, the communication strategies, to the policy maker, the doctors. Someone asked a question about the need for a curriculum about communication for students of medicine and all of that. And I think this is a first step in that direction. Thank you. So, book unveiler, sir.
Okay, thank you very much. Ladies and gentlemen, this is the test of the pudding, isn't it? Is it not in the eating? Yes. This young lady has done so much, put her talents, her energy, and her resources to produce this book. This is the time for us to make sure that we support her. And the support will be in two stages. One, everybody in this room, if possible, should come pick a book. Everybody should come pick a book. I hope we have enough. I might see you coming to pick a book. Okay. And then when we pick a book, we need to, if you don't pay now, you can make a pledge how much you're going to buy the book. I hear that each of the books goes for 5,000 naira. I think that's reasonable. So the 3 sets goes for 15,000. All right? But most importantly, it's good for us to make sure that this information we got this here today goes around the whole Nigeria, not just Nigeria, outside this country too. So I will give the privilege to my chair to please.
Yes, on behalf of myself and my family, I'm contributing the sum of 250,000.
Okay, thank you very much. I'll give some support. I'll let her know.
Well, I'm glad to be here to support my sister, my friend, my colleague. I'll disclose the amount to her.
Okay. Yeah.
Okay, we're glad to be here on behalf of my bookstore and Adam's Pages. We're the first to promote and sell these books. On behalf of the bookstore and the family, we donate 100,000 naira.
Go ahead.
After you.
Yeah. We support this project with 250,000 naira.
Thank you, Dr. Yutinji, for inviting us, and we're very happy about this. This is a cornerstone of healthcare. We want to support it. I'd prefer to be anonymous, but I know people don't like that. So we'll do for the books and for the foundation for ₦1 million.
Thank you so much.
You now see why I wanted to speak first. Well, on behalf of the Oyetunji family, we take each of those books for 100,000. That means for the 3 of them, 300,000.
Yes, on behalf of myself and my daughter is a physician. She's a is a senior reg in the University Teaching Hospital. At least I'll get the 3 sets for her for 150,000. Or 10 sets, I guess. So, ladies and gentlemen, can I get anybody from the floor who wants to support? Please come forward. Anybody who wants to support?
So I think we can pass the microphone round.
Yes. And then...
Thank you so much.
Yes, go down.
Thank you so much, my very special dignitaries, for making this important book unveiling worth the while. Okay, yes, so we have someone.
Okay, thank you very much. On behalf of the Medical and Dental Consultants Association of Nigeria, FMC Abuja, and the Nigerian Medical Association, FCT, I want to support with the sum of 100,000.
Congratulations, Dr. Yetunji. On behalf of my president, Medical Initiative for Africa, we'll do 150,000 naira.
150,000 naira. Thank you so much, and thank you so much for what your institution is doing. We appreciate it. I hope our ushers are here taking notes of this goodwill, financial support, and donation for the books. Yes,
Okay.
sir, please.
Okay, thank you very much. On behalf of the Medical Women Association of Nigeria, FCT chapter, and Dr. Temitope is one of our members. Unfortunately, our president is not here, but the executives are here to represent her. So we will support her, but we'll give her an undisclosed amount. Thank you.
Thank you so much. You are at Amazon, and we appreciate your kind support. Do we have? All right.
Okay.
Can you help me? Yeah. The lady by the aisle.
Okay, thank you so much, everyone. On behalf of the sickle cell disease community, I'm here to support this project, and I will be supporting with 50,000.
Thank you so much, 50,000 naira. Please, ushers, are you here to pass the books to them? Where are my ushers?
Ushers, please go around and make sure. Okay.
Yes, so media, you can also help us by displaying the account number on the screen so that those who wish to get the copies at the production cost can do that. Thank you so much. We appreciate that.
And okay, someone.
Good afternoon, everyone, and it's a pleasure to be here. On behalf of the Association of Resident Doctors, National Hospital, Abuja, I call the convener of this great inaugural patient doctor forum. I call her our member, I call her our sister, our life member, and for her, I believe National Hospital is home for her because that was where she trained. So on behalf of the association, we are going to be supporting this book, and we're going to ensure that most of our members have a copy. So we're going to support with an undisclosed amount, and we're also going to push that this book gets a lot of publicity, and the forum also gets all the support it can. Thank you.
Yes, I think knowledge is wealth. Yeah.
I'm the president of the Association of Resident Doctors, National Hospital, Abuja. Thank you, sir.
Thank you so much.
All right, good day all. My name is Emmanuel Diase. I'm the General Manager of Darby and Partners Nigeria Limited. I'm ably representing my General Managing Director in the person of Dr. Abubakar Salami. We're going to be supporting this with 100,000. Thank you very much.
Thank you so much. Ushers, please ensure that they get the books and the right copies.
Details.
So while we're still taking this goodwill support for the author, I would like for us to quickly go on the next item on the agenda. But before we do that, I think my colleague wants to acknowledge one or two persons here present.
Okay. Should have come a bit earlier, but I want us to just give a round of applause to the Group Medical Director of the Limi Hospitals, Dr. Iseko. Thank you, sir, for coming today. And just an addendum to the rest of the house, both virtually and in-house. If you want to support, or I do encourage everyone to at least have a copy of the books, you can feel free to reach out. You don't have to also hold a mic, and you can support in any way possible. Thank you.
Thank you so much. So we're going to the next item on the agenda, which is the presentation of award for the Gabriel Oyetunji Award for Compassionate Care. And to do that, I'd like to invite Dr. Aminu Yusuf to do us the honor of presenting this award. Do we have Dr. Aminu Yusuf? Please a round of applause for him as he comes forward. And he would be presenting this award to a recipient today for Dr. Yibara Akpama. This is a round of applause. We had over 400, right, and plus nominations for this prestigious award, and we got a winner for it, and Dr. Aminu will do us the honor.
Thank you. First of all, I want to use this opportunity to thank the organizers and my brother, my friend, my confidant for inviting me to this program. Let me tell this audience that Itayo is the Honorable Federal Commissioner, National Population Commission representing Oyo State. And I must say, I met him there, but by my assessment, he is my best commissioner. Since I came, I've been learning from him. He's a resource person, very intelligent person. In fact, he is an encyclopedia when you talk about MPC. So I thank you for inviting me here. Yes, you brought me here, and I have learned something. I'm not a medical doctor, but I'm a PhD doctor. So therefore, I stand here as a patient, not a medical doctor. But what I learned is that about patient-doctor relationship. I think this is a foundation of healthcare. When it works well, patients recover very fast or faster. And then the patient, trusts the system more, and doctors find their works more meaningful. When it breaks down, both sides suffer. So, I think with this sensitization, I think we are privileged for those of us who attended this, most especially myself. I've learned a lot, and we pray that it will not break down. The relationship will continue to. Thank you very much for giving me this honor to make this presentation. Okay. On behalf of Oyetunji family, I want Dr. Aminu Yusuf, Talban Wushishi, Chairman, National Population Commission, I present this to you on behalf of the... This one?
Please, a round of applause. You can see the beautiful plaque I've received. 500,000 naira. Congratulations. Congratulations, you've done well. We read your beautiful stories, and we know that you've done very well. Thank
Touching.
you so much.
Thank you, sir, so much for this. Thank you, sir. Can we give a round of applause? Come on now.
So our recipient will just say one or two words to us, very quickly.
Good afternoon, distinguished guests, respected colleagues, members of the Patient Doctor Forum, Nigeria, friends, family, fellow healthcare professionals. I stand here today deeply humbled and sincerely grateful to receive this inaugural award of Gabriel Oyetunji Award for Compassionate Care. To be recognized for compassion, especially in a profession as demanding and deeply human as medicine, is truly an honor, and I don't take it lightly. I would like to thank God for this privilege and also thank the organizers for this recognition. As an obstetrician and gynecologist, I have had several privileges working with women and families through some of the most vulnerable, emotional, and life-changing moments of their lives. From the joy of safe delivery to the difficult nights of uncertainty and loss, I have learned that patients may not always remember every medication prescribed or every medical term explained, but they would always remember how they were treated and how they were made to feel. Today, global health continues to emphasize not only evidence-based medicine, but also the importance of a positive pregnancy experience, a respectful maternal care, respectful childbirth practices, and shared decision-making. We are constantly reminded that beyond achieving good clinical outcomes, every woman, every man, every child deserves to feel heard, respected, informed, safe, and dignified throughout their healthcare journey. Compassionate in healthcare is not merely being kind. It's listening when the patients are afraid. It's showing patience when they are overwhelmed. It's preserving dignity even in difficult circumstances. It is reassuring a mother in labor, comforting a grieving family, and remaining present even when medicine alone cannot provide all the answers. This award, therefore, is not just about me. It belongs to every patient who has trusted me with their care, every mentor who has shaped my journey, every colleague and health worker who continues to serve selflessly despite enormous challenges, and my family and friends whose support and sacrifice made this work possible. I also dedicate this recognition to healthcare professionals across Nigeria who continue to give their best every day under demanding conditions. Your compassion may go unseen, but it changes lives more than you may ever know. Finally, I pray that this recognition would also inspire other health workers to embrace not only competence, but compassion, not only knowledge, but empathy, not only treatment, but true patient-centered care. May we continue to combine scientific evidence with humanity, because the best outcomes are achieved when clinical competence meets compassion. Thank you once again to the Patient Doctors Forum Nigeria for this journey. We will all continue to heal, not only with our hands and minds, but also with our hearts.
Please, a round of applause. Thank you so much, and congratulations.
Thank you, Ma.
All right, so before we take a break and go for lunch, I just wanted to share a joke about the whole idea of what communication can do. There's this professor whose house was burning, so he wanted to reach out to the fire service to help him put out the fire, and so he called. And the moment he called, he started in his professorial, lexicography, say, gravitate here with immediate acceleration and with a stupendous alacrity. A gigantic conflagration has engulfed my domiciliary habitat. And so they had to go looking at the dictionary. And before they got to Professor's house, his house has been razed down. So I think communication is a true traffic way. It's something that when you encode, the other person should be able to decode. And that is the essence of today's forum. And I hope we're still on board this flight. Inaugural Patient Doctor Forum, flight 2026, 16th May. So we're not done yet, but we'll take a short break. And when we come back, we will go on the second panel sessions. Are we all in agreement that?
Just a little bit of a trailer on insights. While we go on our break, bear in mind that I'm sure we all enjoyed the first panel discussion. We have one more on designing healthcare systems that enable better patient-doctor communication. So stay tuned, keep yourself refreshed. It's going to be one of a blast. One more thing, during the break we can take pictures with the panel outside, feel free. And check out the books. If you want to have a glance through them, I promise you see something you love. Thank you.
And I'm still selling books. Thank you. You can always come get a copy. Get a copy for your friend. Start out that community library and empower members of the reading public. Thank you.
So we'll be taking some photographs now with the panel.
Just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me when you're not strong.
Break. 10 minutes.
You need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. If there is a load you have to bear that you can't carry, right off the road, I'll share your load. If you just call me, come on everybody, call me. If you need a friend, call me. Oh, baby, just call me. If you need a friend, all you got to do is, call me. All you got to do is, all you got to do is, call me. Come on now, call me. One more time now, call me. We love you, Bill. We love you, Bill Rivers. Yes, sir. Sometimes in our lives, we all have things just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me when you're not strong. I'll be your friend. I'll have you carry on. Oh, it won't be long. I'm gonna need somebody to lean on. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. If there is a load you have to bear that you can't carry, right up the road, I'll share your load. If you just call me, come on everybody, call me. If you need a friend, call me. Oh baby, just call me. If you need a friend, all you got to do is call me. All you got to do is all you got to do is come on now, call me. One more time now, call me. We love you, Bill Willis. Yes, sir. Sometimes in our lives, we all have pain, we all have sorrows, but if we are wise, we know that there's always tomorrow. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, for it won't be long till I'm gonna need somebody to lean on. Please swallow your pride. If I have pain, you need to borrow, for no one can feel those of your needs that you won't let you. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me
can tell our friends and friends of our friends outside to please come back inside. We're about to begin the second session so that we can wrap up for the day.
Our participants, we have about 10 more minutes and we go into the next session. 10 minutes and please let's start to return to the hall. Attention, we have 10 more minutes for lunch, break, and networking.
Sometimes in our lives, we all have.
Please, ushers, you do me.
We all have sorrows, but if we are wise, we know that there's always tomorrow. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, boy, it won't be long till I'm gonna need somebody to lean on. Please swallow your pride.
I've seen the food.
If I have pain, you need to borrow.
Please, we have 3 more minutes. If you have a friend that's outside, please help me to tell that friend, to tell his friend, and the friend of that friend that knows that friend to please come inside.
We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me when you're not strong. I'll be your friend. I'll have you carry on. Oh, it won't be long. I'm gonna need somebody to lean on. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand.
Please, we're about to commence the second session. Please, can we all come in?
We all have sorrows.
Ushers, please kindly help us get them back inside.
Always tomorrow. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, for it won't be long till I'm gonna need somebody to lean on. Please swallow your pride. If I have pain, you need to borrow. For no one can feel those of your needs that you won't let you. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, it won't be long. I'm gonna need somebody to lean on. You just call on me, brother, when you need a hand. We all need somebody to lean on.
Ushers, please, can you help us get our participants back inside the hall? We're about to commence the second session. Thank you.
There is a load you have to bear that you can't carry. Right up the road, I'll share your load. If you just call me, come on everybody, call me. If you need a friend, call me. Oh, baby, just call me. If you need a friend, all you got to do is, call me. All you got to do is, all you got to do is, come on now, one more time now, call me. We love you, Bill Rivers. Yes, sir. Sometimes in our lives, we all have pain, we all have sorrows. But if we are wise, we know that there's always tomorrow. Lean on me just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. If there is a load you have to bear that you can't carry, I'm right up the road. I'll share your load if you just call me. Come on, everybody, call me. Hey, if you need a friend, call me. Oh, baby, just call me. If you need a friend, all you got to do is, yeah, call me. All you got to do, yeah, all you got to do, come on now, one more time now.
Hope we feel a bit refreshed. Let's settle in. Let's settle in. Please, those of us outside, let's come in as we go into the next session.
Please, can the ushers help us so that they can... all
Can the
come-
protocol team outside please help redirect our participants?
Sometimes in our lives, we all have pain, we all have sorrows. But if we are wise, we know that there's always tomorrow. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, boy, it won't be long till I'm gonna need somebody to lean on. Please swallow your pride. If I have pain, you need to
Can we please come in? We know the food is good, but this is gooder.
you just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. Hey, we all need somebody to lean on. Lean on me when you're not strong. I'll be your friend. I'll help you carry on. Oh, it won't be long. I'm gonna need somebody to lean.
Okay, so before we go on, I'm dropping into the crowd. I just want to see one or two people tell me about how the program has been thus far and what the patient-doctor forum means to them, what they understand. Casual talks, nothing out of the ordinary. Is there any volunteers or do I pick somebody? If my eye or eye jam more than 2 seconds, I'll pick you. Just tell me how your experience has been thus far today. You can still tell me the food was good. That's okay.
Hello, everyone. Thank you. The event has been amazing thus far. So far, what I've been able to learn and take away so far is the Patient-Doctor Forum is just giving us information on how to bridge the gap between patient and doctor interactions, how to make it more standard, and also to treat patients with more empathy, care, and improve quality of healthcare in general. Thank you.
Can we give her a round of applause? Thank you so much. So ultimately, we're learning that there's always multiple sides to a story. There's A, B, and what actually happens. Sometimes it's difficult to be objective in a particular scenario because everyone has their paradigms, has their own purview of how things have occurred. But that's why the Patient-Doctor Forum exists, for these conversations. If you've ever walked into a hospital feeling like you weren't heard, the doctor didn't pay attention or take good care of you, this is why it's important. Because from the doctor's side, he's overworked, overexhausted, a system that is broken, and he's just trying to get by the day. It's not to say that care shouldn't be taken, but this is why these conversations happen. So that when we understand everything that surrounds it, when we build initiatives, when we push advocacy and for policies, then we're able to make Nigeria better. Because it starts here. I remember, or should I say this, over the past 2 weeks, we've been seeing plenty dragging online. Both medical practitioners dragging patients and the other way around. And this is why the move starts here.
So good afternoon, everyone, and thank you all for your patience. I'm sure we've had a robust conversation so far. For those of us who are just joining us, this is the inaugural Patient-Doctor Forum 2026 happening here live at the Sheikh Musa Yar-Adua Center with the theme Humanizing Healthcare in Nigeria, Empowering Patients, Caregivers, and Providers. I would like to especially acknowledge the presence of our PAMSEC here present, Dr. Camille Sherita. I hope I didn't murder your name. I apologize if I did.
Can we give a round of applause?
From the Ministry of Labor. He's a doctor. And we appreciate your presence, sir.
Thank you so much for coming, sir.
You're welcome. Please, for those of us at the last part of the aisle, can you please come forward? I don't know. We need to fill in the seats at the front for the cameras at least. So we would launch into the second panel proper. And to do this, I'll call on the panelists. The topic for the second panel is designing healthcare system that enables better patient-doctor communication. Remember, at the heart of today's discourse is communication. If we have breakdown in communication, even the doctors will not do their work well. I remember going to the hospital one time, and I know it's usually that time where the chloroquine is very much in vogue. So the doctor will ask me, do I have fever? I'll say no, because I don't want injection, and I know at the end of the day, I go taking some painkillers and all of that, which really doesn't help. So to do justice to this panel topic, I would like to invite Dr. Lawson Ekwere, if he's here. Please, a round of applause for him as he comes to stage. I'd like to invite Dr. Omolara Olagunju. Please, a round of applause for her. Please, can Dr. Abdullahi Nasiru join us? And I have Dr. Emmanuel Okechukwu. Please, a round of applause for them as they come to the podium. And to do justice to this, I would like to invite the moderator. And our moderator for today's conversation is no other person than my friend. I call him my friend, and I like to call his name for short. I call him SB Tanko, but for those of us in the field, we call him Dr. Sani Bala. Please, can you come forward? He is a surgeon. He is a writer. He is a TEDx speaker. And he would be driving today's conversation as the moderator. So, Dr. Bala, over to you.
Thank you very much, Masters of Ceremony. Good afternoon once again, distinguished ladies and gentlemen, distinguished guests, my respectable teachers and senior colleagues, members of the Patient Doctor Forum. Thank you very much for your attention. We'll start right away. I would like to introduce the panel of erudite professionals I'm privileged to share a session with. I would start with my right, Dr. Lawson. He's a general practitioner who has over 12 years of experience. And we have Dr. Omolara. She's a consultant and a founder of Cardiovascular NGO. She's actively building patient-centered systems in a private setting. Dr. Nasiru Abdullahi is a consultant microbiologist and pathologist. He is a chairman of the MDCAN FMC Abuja. He's a clinician, a health law and policy expert, and institutional and regulatory expert. The last but not the least is Dr. Emmanuel Okechukwu. He's a public health expert and a researcher, and he has a vast and wide experience in rural and faith-based healthcare. He is also an expert in delivering healthcare to underserved communities. Thank you very much once again. So, due to lack of time, we'll be snappy and then we'll keep to our time. This session, we have 2 minutes to answer the question and do justice to the question as well. So I'm throwing the question to all the 4 panelists. Between the 4 of you, SARS and Ma, you have seen the Nigerian health system from various perspectives. As I earlier introduced, we have the public health specialists, we have the people in the private sector, we have people involved in policy making, we have people practicing in the private sector and doing very well. So with your vast experience, in your honest professional assessment, Nigerian healthcare system is currently designed in a way that supports, do you think it's designed in a way that supports good doctor-patient communication? Because we've been emphasizing and reiterating about communication between doctor and patient, communication between healthcare givers. So do you think our system is designed in such a way that it will enable this communication from your different perspectives, from your different prisms? And what has been the consequences of both patients and then the healthcare givers? Let me start with Dr. Nasiru Abdullahi.
Okay. Thank you very much. Good afternoon, esteemed audience. I think a lot has been said by the previous speakers, the previous panelists concerning this matter, looking at it from the policy angle, down to facility, the healthcare providers. When you look at the policy, there are some policies actually that are in place with regards to ensuring better patient and doctor communication. If you look at the medical and dental practitioners, thank you. I said some policies are actually already in place. They may not be adequate. For example, there are provisions in the Code of Medical Ethics of the Medical and Dental Council of Nigeria with regards to providing patients adequate information on their health status, letting them know the various options available for their diagnosis as well as treatment, as well as the risk, the benefit, and consequences of such treatments. Doctors are to be familiar with this, but how many of us actually take our time to go through some of these documents? That is the issue. Now, what is the knowledge level of the patient with regards to this aspect of the Code of Medical Ethics? They also need to be aware. It brings me down to the issue of sensitization and awareness creation for both the doctors and the patients to be informed of what is contained in this relevant document. That is one. Two, it is based on information that you provide to the patient that will make them to make informed decision about whatever intervention you want to bring forth. So it is also contained in this document I have mentioned. That's the Code of Medical Ethics. Then the National Health Act 2014, Section 22 down to, if you go to Section 23 down to 27, is explicit on the obligations on doctors to provide adequate and comprehensive information to patients with regards to their health status, the treatment modalities, and their risk, benefits, consequences, the options, alternatives that are available, as well as their risk, benefits, and consequences. And with a view to enabling the patient making a decision on the choice of treatment that should be implemented for him or her. How well are we informed about this is another issue, as well as the patients. That also brings us to the issue of awareness creation for patients to know that there are provisions like this in place that makes it obligatory for doctors to do this to them and for them to be aware to demand this information. Three, when you look at the Federal Competition and Consumer Protection Commission, the Act 2018, there are what we call patient bills of rights. They are clearly mentioned there, and one of them is for doctors or healthcare providers to provide adequate information to patients on their health status, the treatment, even the cost of such treatment must be clearly stated. Then, at the level of the head of service, you have a SAVICOM, angle to make sure that patients who come to access care, as well as all other forms of, should be able to access quality healthcare services. However, on this, when we now look at how well has it been implemented at the level of the facility level and healthcare providers, a lot of things has been said with regards to the structure in place. Do we have enough consultation rooms for the large number of patients that come on daily basis to seek care in the hospital? In some hospitals, 2 patients are even attended to in a room, which does not allow for confidentiality. So there are instances where patients may not be able to provide sensitive information that they may want to give to doctors because of this.
Yes.
2, barrier in terms of language. How many hospitals have language interpreters to be able to help those who don't understand the language of their patient and make it easy? So in similar claims, we have this in place where you have some staff of the hospital employed solely for this business so as to help doctors interpret.
Thank you.
There are other things
Thank
that
you very
we
much.
mentioned. Thank you.
He is an encyclopedia of knowledge. Thank you very much. So, Dr. Olagunju, from your own perspective, you've been into the private care practice and then you have a non-governmental centered care. So please, would you shed more light on what Dr. Nasiru said and give us another perspective from the private institution setting, from the private establishment setting? Would you briefly tell us your own perspective? And do you think that communication is well established within our settings?
Thank you very much for the question. Am I audible? Okay. Thank you very much for the question.
Yes, so I've been in private practice for about 4 years, even though I have a background in public setting as well. So I've been able to see both sides of the story. And what I can say categorically is that it's about having the same problem but in different phases and showing itself in different ways. Yes, back in the public sector, there's little or no, let me not say not much importance is placed on adequate communication, except you are in places where you are undergoing some training, right, where you know someone is supervising and you just must do the right thing. Otherwise, left alone, you just shove some things down the patient's throat, and it's up to the patient to take it or not. However, it's a little different in the private sector because private sector is cash and carry. If you come to my hospital, you don't like what I do, you do what? You move to the next hospital. So because we are aware of that, the private setting is a bit more cautious and conscious of the fact that they must communicate. But essentially, we still have a lot to do in ensuring that communication is effective and empathetic, just as we have said all the while. In my hospital, I usually tell the staff I work with, I tell them that a chain is as strong as its weakest point. The weakest point may not be the doctor necessarily. Yes. The weakest point may just be the security official that talked rudely to a patient as he was driving in. And that patient bottles that anger and decides to give everybody, right, just at the point where he can. And eventually he may get good health care, he may feel better, but he's still upset about something. Yes. And little things would then trigger such a patient at the point where he should necessarily not be triggered. So that's the important thing about communication. Yes, doctors are at the center or very close to the center. I would say patients are at the center, but everybody in that hospital setting has a responsibility to communicate effectively with the patient. Thank you.
Thank you very much for that insightful response. That's from the prism of the private practice. So now, Dr. Okechukwu, with your wealth of experience in rural medicine and then healthcare delivery to underserved communities, there are different perspectives. We are talking from a highly urbanized places like Abuja, but you have an experience in faith-based organizations. So what's your own experience and what would you tell us and the audience about the importance of communication, and how do you think communication has been working in such establishments that you are so conversant with?
Thank you for your question and good afternoon, dear audience. I've worked for I didn't work for government, so I worked throughout the faith-based Catholic health system. And as I've been said, in terms of training, content, curriculum, we passed through the paternalistic model of training, where you are taught to be a good professional, to deliver care, quality care. But that is the science of health care delivery. What is lacking, even up to today, in most cases, is the relational part of training, the art of delivering that quality health care. This lacuna can be filled by the institutional culture in which the healthcare practitioner does his work. So in the faith-based health services, even though we come from the training that may not have properly prepared us to do what the expectation has been all this day, but the system we operate is that every patient coming to our facility, for instance, is not another statistic, it's not another number. It's not the sick person, but it's the human person in need. That changes the orientation of the healthcare worker. This work ethic changes to see that I'm not going to treat only the sickness, the headache, the malaria, the typhoid, but a holistic approach to the patient is what is required. And that's the training we get in addition to the formal education we obtain from our medical training. So, to answer the question, is the environment makes a person. Where you work, how the system is set up, how it operates, the checks and balances, the mutual accountability system that is there helps the person to reorientate. And therefore, the faith-based health facilities seem to add, in addition to the formal education, the faith dimension. Look at the person as someone created in the image and likeness of God like you, and therefore your attitude towards him or her, even though they are sick or she is sick, it should be different.
Thank you. Thank you very much for that response. So, over to you, Dr. Lawson Equerry. What would you add from your perspective about communication? And we have 2 minutes to proceed to the next.
Okay, thank you. I've heard a couple of things my panelists said. I think I will not hammer on them too much, but I think I'll just stick more to the patient and doctor relationship. They've hammered on policies and a couple of other environmental factors here and there, but I usually see this challenge as something us doctors have to actually put our minds to. For example, you see challenges of, for example, the rooms are not conducive for you and the patient, but what are you doing as a doctor to make sure that on your own part you've actually fulfilled your role to that patient? Because a lot of the time, yes, we blame policies, we blame one or two things, which, yes, is multifactorial, but what have we done on our part as doctors? A lot of the time, we don't have that training.
Can you be specific?
Okay, for example, when we are talking about conversations or communication with our patient, there are certain settings that are usually more conducive for them. For example, we have a lot of times that a patient come into the office and maybe the doctors are not really smiling, or in this case now we have EMRs that do not allow us to engage or face our patients directly. These are the cornerstones of communication, not necessarily even in the medical practice. And when you don't have that, you're already feeling short. For example, patients come, instead of you facing them, you're probably facing the other area or doing one thing or the other. These are the little things that on your own as a medical practitioner you could do to help offset the balance. If at all they have had encounters outside, maybe through the nurses or other forms of lineage leading to where you are, you could be the one that helps offset it. I'm saying this from a practical experience where obviously our patients have encountered the security, maybe the front desk or the nurses, and maybe are not too okay with whatever interactions they've had. What have we done as a doctor to help bridge that gap? So as I just believe the training, you get it, not necessarily the medical training itself, but training in communication is quite important. These things are also taught in several other areas, which at this point in time I will not really go into.
Thank you.
Yes.
Thank you very much, Dr. Lawson. So, discussion centered around policies, the ones we have available, the evolving policies, the ones we don't know about, and then implementation of these policies. Yes, we have the policies, but implementing these policies, the systems put in place to ensure compliance, that we have these policies to ensure smooth handling. And then also from the faith-based organizations, yes, they have these people in rural settings, but they view them holistically. So they earn these people's trust, and then there's so much communication because you deal with the person from the religious perspective. And then from the private perspective also, you know that the patient, your salary comes from the turnout of the patient, so you won't do anything to jeopardize the income of a center or facility that feeds you. And then what I want to specifically acknowledge in Dr. Lawson's closing remark is the responsibility. Yes, we identified the lapses, we identified from the perspective of the patients, from the system, and from the doctor's perspective. But then challenges are there. But within the challenges, what do you do as a doctor, as a leader, to navigate your way around that, to ease those challenges, and then to enable a seamless healthcare delivery, despite things that are not rolling too well? And then we as doctors are burdened with this responsibility of finding a way to make things work in environments that are not too favorable. Thank you very much. So we are still proceeding. It's still communication. Dr. Olagunju, so back to you. Private healthcare is often assumed to provide better communication simply because, as you mentioned, I'm using your opening statement as a foundation. You mentioned that the patients pay more, and then if you don't treat them well, they have barrage of other options to go. So we often assume that private practice, like private centers, they have more communication skills and more doctor-patient communication because they pay more and then they give more services. But in your experience, is that always true? And then, do you have any communication failures in the private settings that we do well, that they still avoid talking about openly? Because you've been there with over a decade of experience in that sector.
Thank you very much for the question. So yes, the communication in the private setting is not automatic. It has to be grown. A few things I have been able to identify is the fact that, first of all, that open line of communication must exist, even within the workers. If you want your staff to communicate very well with the patient, they must feel free to even talk in the first place, right? So the management and staff must have an open communication line whereby they can come to the management and report things openly without any fear of prejudice or whatever it is. You know, they should be able to come to you comfortably and communicate with you. There's this thing we inherited of fear and reverence and trembling with our teachers that usually makes it very difficult for you to open up. So that is something that should be developed and cultivated. Trust. Now, another thing that is very important is training. It's been emphasized since morning that a lot of times these doctors aren't trained, the staff aren't trained appropriately and enough when it comes to communication skills. So you must assume that the people you are working with are not trained. And so because of that, you invest a lot into training. Yes, I can get a fresh graduate from school who isn't trained in communication, but as an employer of labor, my responsibility remains in training that person to ensure that he or she gives the service the way I want it to be given. And that has to be emphasized, and it's not something that you do once and for all. It's continuous training. So are there communication areas that we still shy away from, or some private hospitals still shy away from? Yes, there are many. Sometimes the patients are not carried along step by step. The relatives are not carried along step by step. There are some patients you see, as medical professionals, you know already that the prognosis isn't so good, but you're not feeding these relatives the information when they need to know.
Okay, could it be because maybe you think the patient would default and not agree to the treatment and then possibly cutting the income of the hospital? Maybe they're being economical with the information for fear of losing the patient and whatever the patient has to pay to access the services, which in turn boosts the income of the hospital. Could it be a factor?
Well, yes, it's very possible because, I mean, this is private practice. It's cash and carry, as I said earlier on. We need the money to run the system, but we must not forget patient first, not money first. And patients have a right to their autonomy. They have a right to move to the next facility. I don't have a responsibility to hold them down. My responsibility is to make them see what exists and what is possible, what is obtainable. They still have the autonomy and the right to take a decision to stay or not to stay. So I should not hold back information because I want them to stay and get some more money from them. That's totally wrong, and it's not ethical to do that. So the important thing is to feed them the necessary information they need to have so that they can make an informed decision. Yes. Most times, if you do your job well, the informed decision that they will make would eventually be in your favor. So you shouldn't keep information just to hold somebody back. I don't think that's right.
Yes, thank you very much. For the want of time, we could have gone on and on, but I think you've done justice to this. So over to you, Dr. Abdullahi. So we have 3 minutes to answer this. You work in an intersection of policy, clinical care, and then institutional leadership. So from your experience now, your vintage point in the public health system, in the Nigerian public health system, what are the structural realities that make the patient-doctor communication difficult, even for well-intentioned individuals? Because Dr. Lawson made mention of us as doctors, or the doctors in the private and public sector, to have the zeal to work and then to be instrumental towards navigating their way despite the challenges. So if you have this intention now, what are the structural challenges that will prevent, despite the good intention, despite the effort being put in by the doctor, what are the structural challenges that will prevent efficient doctor-patient communication? We have 3 minutes.
Okay, thank you very much. First, this has been mentioned previously, the issue of inadequate manpower. A situation where a doctor has to attend to 100 patients in a clinic. And you also don't forget that the waiting time of those patients is important. Patients often comply when you have to attend to a patient spending between 15 minutes to 20 and some people are still outside waiting for them to be called in. So inadequate manpower is key in the whole thing. So it limits the time you actually will need to communicate effectively with your patient towards making an informed decision. Second, I mentioned the issue of barrier in language before, and I went ahead to suggest a way to get that one solved. That institutions, hospitals should have people employed, particularly if in a culturally sensitive environment, have people employed that understand the language of the predominant people there, so that in the event that a particular doctor attending to a patient doesn't understand the language, because it's one of the barriers in effective communication. So those people can be employed to help in resolving the issue of barrier. Okay. Then, third is the convenience, conduciveness of the consultation rooms. You know, there are certain health conditions that patients will want to give you so much information about. But because the room is not soundproof and the fear of other people around getting to hear about what they want to disclose. Take, for example, someone with sexually transmitted infection, or the person will not be, it won't be convenient for the patient to be able to give you all the information that he needs to give you, because he feels there are other people that may be listening to what he or she may. I have seen situations where 2 patients are being consulted in a room because of inadequate facility, consultation rooms. So such is not good enough. Then training, very important. In our training curriculum as medical students, when I graduated, there was nothing like communication skills, training. So I only got to be trained communication skills-wise not long ago. So you can see that if it's different from the biomedical aspect of healthcare, because you need to know the techniques of getting those information, making that relation robust, trusting, and ensuring shared decision making. So if you don't have that skill in communication, of course, it may just be the reason why the patient may not be satisfied and the outcome may not actually be good. Then again, it's important that there should be technology introduction, telemedicine and other things that we need to be bringing in. Even in situations where we cannot give the sufficient information, there should be need for feedback so that patients will have access to their medical record electronically, yes, so that they will be able to now express their concerns through there, that will be available to the caregivers for them to know and respond to. Yes. Everything must not take place within there because of these inadequacies that we have mentioned. Platforms should be created so that the patient has access to their records, and there should be opportunity for them to express their concerns and feedback that the hospital will take into mitigating against issues that communication gap will cause. There are so many.
Thank you very much. So you listed some alongside the solutions, but do we have a timeline? Which ones do you think among the barriers now could be fixed, let's say 1 year, 2 years, among the challenges and then the solutions? Because I noticed you mentioned the challenges alongside the possible solutions. So which ones are could be implemented with immediate effects, maybe within a year or 2, could be adjusted?
I think it's important that we are trained. Very important. Okay. It's not all the deficiencies that can be addressed within 1, 2, 3, 4 years, but it's key. If we are well trained in communication skills, it will go a long way in helping us bond stronger with our patients towards establishing a trusting relationship, robust communication that will elicit all the information you need and the information the patient also needs towards better patient care. Very, very important. So if you are looking at between now and the next 2 years, because if we are talking about inadequate manpower, it has been there from time immemorial, and it will continue to be there, because the WHO, recommendation of budgetary for health sector is 15% of our annual budget, but I am not sure whether we have been able to get to even 7%. The highest that I am aware of has been 5 or 6.
Wow.
So, and you can imagine that even providing this infrastructure, consultation rooms, employing enough doctors to be able to man the overwhelming demand of patients in the hospital, it's not something that can be addressed considering the limited availability of resources in the country. So we have other sectors that are competing, and therefore we must have a way of ensuring that things are fairly shared to accommodate other sectors. So these are first training,
training and then policy in terms of resource allocation. Thank you very much. So, Dr. Okechukwu, back to you again. I have so much respect for the fact that you've been practicing in faith-based healthcare delivery and then in healthcare delivery to rural and underserved communities. So we know the dynamics around the urban centers, and then we know the dynamics and the specific challenges happening in the rural settings. So you made mention of how they are able to navigate and then ensure that there is seamless communication between the doctor and then the patient. So are there other things now, apart from the communication, that you think the people practicing in the urban area or the policymakers that are concentrated in the urban areas don't know and you want to bring to the fore about the rural centers and practicing in the hard-to-reach communities?
Yeah, thank you very much. Before I come to this question, just to say that for purposes of communication, you said you want to build a good doctor-patient communication. And everything has been around the doctor today. I want to also tell the patient that you have to be patient with the doctor. That the doctor that the woman is a
Please,
doctor.
a round of applause for that.
That a doctor is a woman the woman is a doctor does not remove the fact that she can have her menstrual cramps even when she's seeing you. And so the doctor who is a man has his wife in the hospital or his child is sick, the landlord is choking him. The money is not there. So there are so many things that we should look at. I like what Dr. Akin Moses wrote, showed. There's an environment, which is a macro system. There's a meso, which is institutional. And the individual person to person is just the micro. So the doctor may have been well prepared, well trained to communicate. But circumstances around which he works makes it almost impossible for him to communicate effectively and humanly. However, that's not to absorb him from the need to be as good as he can be. For the rural-urban dichotomy in assessment, I can say that, you see, it's just also the issue of the policy. Policies are made without contextual analysis. Or the implementation of policies are made without realizing that we need to decentralize these things so that what is good in Abuja, what is expected in Abuja, may not work in Odorubu in the Niger Delta, or Talatu Maspara in Zamfara State, all those ones. So my submission would be, just as at Veritas University, the medical school, what we are teaching the students is, yes, this is the general thing, this is the global reality, but you must look at where you are working, where you are posted. That way, you do not think that Abuja should be my village. My village is very far in Anambra State. And it doesn't have the roads, doesn't have the water, it doesn't have the light or so often. So adaptability, being able to adapt, to innovate, to do some things contextually reality, so appropriate technology. If you don't have the big equipments, how can you use your clinical skills to help the patient before you?
Yes.
If you have not been trained in communication, but you know that even good relationship helps you to succeed, you don't become too official. You moderate your attitude, your behavior, your voice, and be empathetic, as has been mentioned. The world is looking for those who listen. But because of the volume of work, doctors do not have enough time to listen. But as has been said, if people listen, the patient can get cured.
Thank you very much, sir. So, Dr. Ekwere Lawson, so you've been in the front line in healthcare delivery, and you are the head in your own clinical practice. So what do you think over time, what has been your experience? What do you think are the expectations of a patient walking into your consulting room? What are the expectations? I mean beyond prescriptions, beyond investigations. What other expectations does the patient want at the end of the day after consultation? What does he want to achieve?
Okay, so I think this goes without saying, I think everyone is even going to agree. They just want to be heard.
Okay. Communication.
That's all.
Communication.
They want you to listen to them. And this is not just sitting down and not talking while they talk. Active listening, which means you are paying attention to what it is they are saying and try to put yourself in their shoes. If you start with this, I guarantee you that your whole session with them will always be great. Every other thing, unfortunately, comes secondary. Because once you start out right, the patient becomes very, very open with you. And information flows. You know, a lot of the time in public institutions, they say, 6 minutes or 13 minutes. I guarantee you, if the patient starts to talk, number one, they will not talk up to that 13 minutes in the first place. And you will be able to figure out what is wrong with them at an instance. It is very, very important. You will realize that because you have been patient with them, you have actively listened to them. Even if something comes up, sorry, we have to, because of time, we'll just, I guarantee you that they're even going to be okay with that. Because you've listened to them. Obviously, in our settings, we are expecting that, or most patients are expecting that you are done with them with a single consultation. So I've come down to the hospital today, I'm having a headache, and that should be the end of my consultation today. But with medical practice, we know it is a continuous thing. So if you're expecting all to be solved in one day, in the first place, it is very, very unlikely that that is going to be the case. But once you actively listen and you pay attention to them, I guarantee you every other thing follows. Oh, I want to do investigations. Yes, these investigations are even very expensive because of the way you have listened to them and attended to them initially.
Yes.
A lot of these things flow. You realize that they are much more open to accepting investigations that you may have thought may be too expensive for them, or they don't have any conception of it. In short, they won't even want you to explain what investigations you're going to do for them.
That's true.
Yes, because, they already have, the way you've attended to me, I'm fine.
That's
the other
true.
doctors
Thank
may have not have done that.
The masters of the ceremony are sending reminders, so we have to stick and make it snappy. So the next question now, I'm throwing it open to the 4 panelists. I want each of you to, within 2 minutes, to paint a practical picture for us. Imagine a healthcare system where communication is working well, not a perfect doctor, but a well-designed system that would enable in bringing out the best in not just the doctor, but the other members of the healthcare system. So what structural condition needs to exist for a patient to leave a consultation room feeling heard, feeling understood, feeling informed, respected, and above all, clear about what's about to come next in terms of follow-up? So I would want to give 1 minute each for each of our panelists to give their perspective. I'm starting with Dr. Okechukwu.
Thank you very much. My 1 minute answer is that let the health facility manager, let the health minister be a public health physician, including going for training on human management of human beings, interpersonal communication. Let the application of those responsibilities, let them have a systems thinking approach. If you have a systems thinking approach to anything, be it even in your family or in your school or anywhere you are going to have a holistic, totalistic, panoramic view of your system. Then you are not going to neglect any one of them, including the issue of effective communication where you are. Thank you.
Thank you very much. Over to Dr. Abdullahi.
Okay, thank you. You said everything is in place, almost perfect. When the patient comes, give respect to them. Put yourself in their shoes. Participate in active listening. Be empathetic to them. And I can assure you everything. Inform them about their situation. Participate in the discussion to elicit information from them, and you also give feedback. At the end of the day, when you process this to make a diagnosis and you allow them to be part of the decision making, I can assure you the patient will feel loved, feel appreciated, and feel treated like a human being and will be satisfied while going. Thank you.
Okay, thank you very much. So what I would say is that we need protocols in place. We need SOPs in place. And these have to be drawn by strong leaders who are informed and well-trained about what needs to be done. And whilst these protocols have been put in place, there must be plan for implementation and evaluation. So putting a protocol to as little as protocol for communication. Oh, a patient comes in, this is what to say. Train your staff when they come in. Good morning. It may look robotic initially, but after a while, everybody will get accustomed to it. Good morning, sir. How may I help you? With a smile. And there's a way to evaluate and check that this is actually being done. Eventually, we'll get things right. Thank you.
Thank you very much, Dr. Lawson.
Okay, so I think just feedback mechanisms. I think if you put that in place, I really do not think that there is no such thing as a completely perfect organization.
Yes.
Yes, there will always be challenges, and no matter how much satisfied a patient leaves your office, they should be made to drop a feedback, because I believe with the feedback they drop, you can actually improve whatever part of the organization you need to, whether it's a structural changes or personnel changes.
One thing is becoming more clear as the communication unfolds. Challenges in doctor-patient communication does not only relate to individual, it also relates to the system. So what we need now is about the systems that are intentionally designed to support clarity, trust, continuity, and understanding. So the final round of questions, 30 seconds. If every hospital leader, policymaker, medical educator, and health professional in Nigeria had one message from this conversation today, what would you want them to remember about designing healthcare system that truly supports better communication and make things better? Message to policymakers, health educators, and then stakeholders within the medical field. One message each. Starting with Dr. Ekwere.
Sure. Okay. I don't think I can say it in 30 minutes, because, 30 seconds. But I feel training, that's all I'll say.
Okay.
Training.
Thank you.
If you give your staff adequate training, the doctors, or the nurses, or the staff, because we are still a community, a team, I feel everything will go smoothly. So training, I'll just
Thank you. Dr. Olagoju.
Yes, please. You read my mind. I was going to say training. And in particular from the medical school level. So this has to be thoroughly embedded and incorporated into the medical school training. So a doctor is trained, he's graduated as a good communicator.
Thank you. Dr. Abdullahi.
Training.
Dr. Okechukwu.
A systems thinking approach. A system is made up of the structures, the processes, and the persons that drive those structures and processes. And therefore, if you are arranging any hospital or any healthcare setting, use a systems thinking approach. That way, you are not going to leave any aspect suffering, including the aspect of capacitating the person who drive, or the people who drive the system. Not only the doctor, as I've been said, from the gate man to the CMD, everybody should be trained in communication, effective communication and empathic practice.
Thank you very much, sir. Thank you very much once again, my erudite panelists. Please, a resounding round of applause for them. And thank you very much to the audience for this engaging silence. So I would like to pass the microphone to the Masters of Ceremony to entertain questions.
Thank you so much. Please, a round of applause for them. This has been very insightful. I stood here, I took notes, and I'm sure I'm going to go home with this note because, number one, I'm not a stakeholder within your value chain, but from what you've said today, I think I have a lot to take home. I want to quickly throw the mic just to see if we have one or two questions, just two questions. Yeah, please, do we have someone to help us pass the mic? Hello, pass the mic. Thank you so much. It has been an amazing day. Thank you. Just pass it.
Thank you very much. I join in appreciating our panelists. Dr. Abdullahi said something very important, which is language. Communication, apart from written communication, is verbal. And verbal communication is in language. And I think it's a very serious matter. Very often, most of us are able to communicate more in our native languages. And most of the time, the doctor may not be able to communicate in our language. Even more seriously is that many of the medical terminologies can hardly be interpreted in our languages. And to make the matter worse, I don't know whether it's part of what doctors learn in college. The way they write is such, is such that no one else, you cannot, and you're giving a patient a prescription, she's taking it to the pharmacy, and she can hardly read what is there. And she goes home and she will take medicines that are reacting to other things that she's taking because she doesn't know or she doesn't know, and so on. How can we overcome this challenge? A doctor cannot be expected to know all the languages. He said getting an interpreter, but that is defeating something else, because you're talking about also confidentiality. And you have someone who is interpreting, and somebody else is there, and how will that not bridge the issue of confidentiality? So the question is, communication is in a language, and yet a large percentage of our population are more comfortable in their native languages, and yet our doctors are not prepared, they are not trained to be able to communicate in all these languages. And more so, like we said this. And then the second comment I have is, I've enjoyed this discussion so much, and this is to the convener now. What's in place to see that the outcome of these conversations will be put in a report or in something that will be made available to those who are not here with us today, such that all these things we are talking about, we can get it across to practitioners and it can become useful in their day-to-day work. So thank you very much.
Thank you so much, sir. I think we have somebody at the aisle there. Yes. I thought we agreed we're going to have 2 questions. Okay, so we're going to have 3.
I'll just say that we've had some very brilliant ideas. I'm sure Temitope is working on a way of putting this together as the first communique of the PDF forum, which should be widely circulated. That would do justice to all of the efforts we've put together here today. Thank you.
Thank you very much for your panel session. I have just one question. Much ado has been said about the role of the doctor to the patient, and our last panelist started hammering on patients being patient with doctors. Could any one of you, if possible all of you, share practical steps that I as a patient or anybody else as a patient can improve on the patient-doctor communication saga that we're having? Because for the most part of this wonderful forum, we've been talking about doctors, and even as doctors, one day we will play the role of patients, whether we like it or not, or patient relatives. So how can we do better as patients to improve the communication? Thank you.
We have. So I'll entertain just one more after.
Okay, thank you. My question is about the training, the health education that's supposed to be provided to the patients. That's from Dr. Abdullah's question, the presentation. So my question is, where do we draw the line, the cutting, between the hospital standards of practice, the preferred practice against the patient's option? And the second question I have here is, this conversation, we should try to extend it to the other healthcare professionals, because empathy does not stop with the doctors. And also, let's talk about primary health centers, please. We have a lot of our patients that are indigent, that are in the underserved community. We should also extend these conversations to them. We should talk more about them, please, because the less privileged are dying every day from issues around our conversations. Thank you.
Good one.
Thank you for the presentation. So I have 2 questions, but they're short. The first one is directed towards Dr. Nasiru. So you were talking about the confidentiality in the space, like in the clinic, where it's too small, but they still have 2 patients there. So a patient will be shady about some things. But now, bringing interpreters, how can you guarantee that these interpreters keep the confidentiality of their patients? Because some people like to talk, some people like to yap. So how can you guarantee this? And my second question is for everybody, but Dr. Olanguju, you can take it. It's for those for those male patients that tend to withhold information just because they are seeing a female doctor, because a lot of them do that. I've seen it. How do you think we can tackle this situation? Thank you.
Thank you so much. I want to quickly ask just one question. First, I appreciate the session. We're talking about designing healthcare system that enables better patient-doctor communication. I like the way the whole thing has gone so far. We talked about it from private, public, and then the faith-based. I want us to see it beyond just the four walls of the hospital. Can we see it to the masses at large? Like, where I'm going to is this: we have so many myths in the healthcare, where you have people believe so many things. They tend to go first, see the the herbalist, try other things before coming to meet us, the doctor. Can we talk more on how we can communicate beyond just the hospital now, and then reach out to these people? You see things happening on social media. So many persons are even appearing as doctors. They are not doctors, but they just give advice, medical advice. How do we doctors, what are we designing in such a way that helps us to address things like this, communicate effectively to the general populace, aside the four walls of the hospital? That's my question.
Thank you very much for your questions. Please, a round of applause for them. So, panelists, moderator, back to you.
Thank you very much for the questions. Though some are contributions, but I will pick the ones that are prominent and direct them appropriately to each of the panelists. Dr. Nasiru Abdullah, you seem to have more questions because you have touched many things. So the first question that was asked was about ensuring confidentiality. Two people asked, because you are introducing a third party to the conversation. So how would you ensure confidentiality if you are using an interpreter? And then the other question directed to you is about the training of the staff for extending it to primary healthcare centers and other cadre of staff, not just doctors, because they are all part of the medical team. And then there was a question directed also to Dr. Jagul. Yes, so Dr. Lawson, there was none. And then the last question was directed to Dr. Okechukwu about the rural healthcare system, like the primary healthcare system, also ensuring effective communication in training the healthcare givers in the rural healthcare system. So briefly, we'll just round up with these answers to the questions.
Okay,
And how many minutes do they have?
Seconds. Yes.
Okay, thank you very much. Just on the issue of confidentiality, according to National Health Act provision, there are 4 situations in which you can disclose the health information of a patient. One is if the patient on his own consent to his information to be disclosed. In that case, but this must be appropriately documented and signed so that at least the patient will know. 2, if such disclosure is, compelled by a law of the land or a judge, a court, that this information should be made known. That is the second one. 3, if it threatens public health, maybe somebody has Ebola now, and the patient cannot tell you to keep the information because it's something that can cause, destruction, mortality, deaths, and so on and so forth. These are some of the situations. So for interpreter, it's not as if you are going to bring an outside interpreter. That interpreter is part of a staff of the hospital, just like the nurse, the hospital assistant, and so on. However, even in bringing such a person, you still need the consent of the patient for such a person to come in. Once the patient understands that there is a deficiency in having effective communication, the tendency is there that the patient will consent to such a person being there to ease the communication between you and him. That is 1. 2, you ask the question concerning the standard. At what point do we draw the the curtain between standard and what the patient wants? According to the laws, it's not as if you are going to invent something outside the norm. What should be available, the various options of treatment. You are not going to invent something outside because that is out of it. Take, for example, you want to treat somebody for malaria, you have artesunate, lumefantrine, artesunate, dihydroartemisinin, piperaquine, artesunate, mefloquine, and so on and so forth. These are options for treating malaria. You must explain to the patient, these are the various drugs available for this. These are the consequences of this one. This is the risk. This is the benefit. This one, this is it. So it's among those things that are allowed for you to use that you are going to, spell out for the patient, mentioning the benefits, the risk, the consequences, and even the cost, guiding the patient to make an informed decision on what you have made available to him or her. So it's not as if you are going to do something that is outside this. So even though you know the standard, it must still be within the realm of that standard for the patient to make a decision.
Thank you.
Okay. There is no preferred practice of the hospital. It's within the confine of what the various options available that you will choose from. Having chosen what you want, and they explain to you the risk, the consequences, the cost and everything, documented, they must stick to what you want because that is what you want. So, sir? It's autonomy. You have the right to decide about your health situation. So they cannot go except, take for example, you want to do surgery. In the process of doing that surgery, something else, more than what you initially thought, you now find it. In that case, maybe the patient may not be awake to seek the person's consent to now go ahead. So those are incidental findings that the law permits, that you should do that in the best interest of that patient. Best interest. Whatever you are going to do beyond what the patient initially comes with for maybe surgeries, you want to do appendicectomy now, you now go there and discover that there is one cancer elsewhere or something that you also need to take out. And the patient is unconscious at that point in time. If the patient has relations around that has been communicated with in conjunction with the patient earlier on, you can actually seek the attention of that and this is an incidental finding that we need to take out because such a person must have been a representative of that patient in ensuring consent taking. So, but as per those options available that you have already made a choice on, despite the fact that they have explained the consequences, the risk, benefit, and the cost, they must stick to that. They cannot change it.
Yes, thank you.
That is on that.
Thank you very much. The conversation is becoming more robust, but we are running out of time. So, Dr. Olagunju, there was a question directed by one of our participants directly to you. Would you briefly answer the question?
Thank you. Doing justice to that, but before that, someone mentioned something about how patients can be what to do, yes, such that patients are also carried along. I think that one major thing that is hampering good communication within the health system is this mystery we have built around medicine, whereby patients are not really, they're not aware. And I think it's our responsibility as part of the system to break this mysterious thing we have around medicine. It's not, we are flesh and blood. I once told a patient I was hungry and he looked at me funny like, oh, so you get hungry? I said, yes, I'm a human being. I get hungry, right? So we are not machines, we are not robots. We didn't drop from heaven. We face the things that these patients face. And because of that, patients must be made to understand that. And it's also our responsibility to educate them. We can churn out educative materials once in a while, make them see, okay, this is what happens behind the scenes. There's no big deal. It's your body, and you have a right to do that, to know everything that is going on. Secondly, to my question proper, how to manage a male patient
preferring or being economical with his symptoms.
Yes, it does happen. I mean, medicine is essentially a patriarchal system, and some of us have been able to enter into the system. However, I would say that it has a lot to do with the proficiency of the female doctor. Before the patient gets to your table, yes, there may be some issues. He may just find out that it's a female doctor in consulting room 2 and say, I'm not going there. That's okay. You don't really have much to say or to do about that. However, once that patient gets to your table, it's your responsibility to be as professional as possible. I've practiced medicine as a postgraduate doctor for over 15 years, and I have seen time and time again that with high-level professionalism and empathy, male doctors open up, and there is no problem with that. It's a question of how you as a female doctor handles the situation. Thank you.
Thank you very much, Dr. Okechukwu. The final words.
Yes, the aspect of how can patients be supported to support the doctor. I have been a doctor for 34 years, and I've also been a patient at least lately. And my experience with my consultant was not very defined. First time he was cordial, but by the next time I came, he was quite abrasive. Why? Because the system has overburdened him. He's been seeing so many patients, he's supposed to close by 2, but by 2 o'clock, they're still adding more patients to his score. So he's looking at me, Oga, do quick. Oga. The doctor that was so respectful of me, he called me, Oga, do quick. So that is what I'm begging the system. PDF should also have patient education sessions. Let us go on air and tell everybody the doctor is not a superhuman person. He bears the burden that the society has put us on. Therefore, patient education, just as we are doing doctor education. So that at the end of the day, the communication will be bilateral, 2 ways. For the rural healthcare system, at the policy level, national, let all the policies not be Abuja-based or Lagos-focused. Let Nigeria decentralize, democratize the application of laws so that contextual realities can be reflected in the implementation. If we do not take cognizance of those rural, marginalized, hard to reach, not reached areas, our universal health coverage mission will not be accomplished. Thank you.
Thank you very much once again to our erudite panelists for analyzing this discussion from different prisms, from different wealth of experience. Thank you very much also to our audience.
Please, a round of applause for the moderator and the super amazing panelists. Please, can we have a group photograph for them? So we don't forget this day of this robust conversation. So while we're doing that, I would like to invite Dr. Camille Shotire to come give us his goodwill. He's the permanent secretary for the Ministry of Labor. Please, sir, you're welcome. Just before you arrived, sir, we had a book unveiling, and I thought you should have been here to also help us remarkably unveil this book. They are of 3 titles: The Smart Patient, The Smart Doctor, and The Smart Parent. Please, a round of applause for him as he comes forward. Yeah. And you are a smart doctor indeed.
Okay, thank you, Salamatu. Distinguished guests, ladies and gentlemen, importantly, our patients in the hall and online, good afternoon. And to thank the panelists. Sorry I couldn't get here in the morning. There were some other engagements I had to. Salamatu didn't introduce me as a medical doctor. I am an obstetrician gynecologist, and I think I practiced for not less than 16 years before becoming an administrator in the Federal Ministry of Health and now Ministry of Labor. So I want to thank the organizer. The invitation came before my deployment as a permanent secretary. So I promised that one way or the other I'll get here to be part of this, especially being the inaugural edition, Humanizing Patient Care. And this is so important. I don't have to say or repeat what the panelists have said, but as someone in government and as a policymaker, there's a Bill of Rights for patients, which the doctors and the health facilities need to do more in publicizing. And of course, the rights of the health professionals are also there, that the patients and their relations also need to be aware of, so that you don't come just because you've seen a long queue and you felt your patient should be attended to in good time, you start fighting everybody. That should be discouraged. And for our doctors, like Dr. Okechukwu mentioned, system thinking. How are we managing our space? As an obstetrician, when I used to practice, I had to reshape the way my clinic was run, because the system I met over time, I started getting more patients and more patients that needed to see me and my resident doctors, and I felt the place was becoming very uncomfortable for the pregnant women. So we had to sit down with the management, make some suggestions, and we're able to make it more comfortable. I love what our federal commissioner mentioned, the issue of interpreters. Even in recruiting health professionals in our health facilities, some of these things are factored into it. You have nurses that can speak certain languages that are very common in the area, and those that are not so common. And we provide opportunities for them to improve their capacity in this area. In counseling, training and retraining, we've emphasized it, but we need to match it with action. So many online courses are available now that we can tap in, not just as doctors or patients. Before I forget, our patients now are on social media. They get different opinions before they see you. And you must be prepared to be able to let them differentiate between what is fake and what is genuine. Because they are going to throw the questions at you. Doctor, they said, if I use this, I'll get this result. What do you think? The tendency is for a doctor to want to get angry. Madam, I thought you came here to consult me. But now you are asking me questions about what you saw on social media. So doctors, we need to be more patient. Active listening is a skill everybody needs to learn, master, and practice. It is. It's part of leadership, and your consultation is also a form of leadership. The patient looks up to you, that once I get there, I think this problem is likely to be solved. Adding more to the burden of the patient is not an expectation. But oftentimes, either intentionally or unintentionally, our actions and inactions leads to this. So managing systems thinking is important. Even if you are a consultant or a medical officer in a particular hospital, the environment in which you operate, how does your patient feel? Look into that and give necessary advice or information to the management of the institution to make necessary adjustments. On the issue of, Madam, Oga, do quick. We all experience this in our practice, and it's still about being well organized. All the patients that come to clinic, especially for those in tertiary hospitals, are by appointment, except that first comers that go to OPD. For general hospitals, we also have to plan. Not that after the clinic has ended, someone came late for clinic. What do? As an institution, you must have a mechanism in place on how to handle it. Not just a security man telling the woman or the man that, you are late, go back and come back next week. That is poor PR for your institution. So we need to look into this, and there are peculiarities to that. What happens in FMC Jabi may not necessarily be what is happening in Teaching Hospital Gwagwalada. So I don't want to go deeper into my clinical practice experience. Now I came here to show solidarity with the organizer, and of course, in the spirit of good relationship between the doctor and the patients. We continue to humanize the way we manage things, we treat them, and at the same time, the doctors too have some rights which must be respected, especially by the institutions, management, and all that. On the issue of policy, we have several policies in place. For those that have not been to the Federal Ministry of Health website, try and visit it, fmoh.gov.ng or health.gov.ng. You go there, you see some of those policy documents. Know the direction government has given to some of these clinical conditions and the way we are supposed to practice. Because some patients are aware of what the policies have said. And by the time they come to your clinic and they are aware that you are not, then you start seeing all sorts of things. Either complaints that are not supposed to come or litigation, accusation all over the place. And lastly, as clinical practitioners, it is incumbent on all of us to be aware of the laws, the policies guiding our practice. That we haven't done well. You need to pay attention to the rules, the legislations, and policies that establish where you are practicing, that surrounds patient care, and also that is related to the various clinical conditions that we manage in country. It is very important. Where you do not know, then easily, even while you are being empathetic, you get into trouble. So this is my message to everyone, and to congratulate the organizers once again. This is an example of thinking outside the box. Ordinarily, our association will not organize this. So we should support it, and I hope that when you are organizing the next one, if I'm aware, maybe I'll mobilize more doctors for you to be here. Because it's a good thing to know that medical doctors, we have several of them now serving as federal permanent secretaries in various ministries. And this is part of the changes that is happening to the profession. We are getting involved to make sure that some of these issues are tackled patriotically with determination to make things better for our country. And also to continue to encourage our practitioners, please look on the brighter side of things. We don't all have to run away. I tell you, if you see something is not working well, bring up suggestions on what we can do to make it better. Thank you very much.
Please, a round of applause for that exceptional remark by the Permanent Secretary. Wow. Before I go to the next section, we're just about winding down. I'm pretty sure there's a lot to take in today, a lot of conversations to be had, and that's why this is the first. And we hope every one of us being here today, I tell you, you're more than just a participant. You're part of a pioneering movement that I've heard what we're doing here to keep pushing, to know that we can expand this and change our system. I think someone asked a question earlier on about what a patient should do. That's why these books are here. The Smart Patient tells you from the patient perspective what to understand, what to do, how to behave in scenarios. And even for doctors too, certain things that you need to understand. It's not just about your proficiency, but a lot of the things that we talk, especially in communication, should not just be an addendum, but a core of our practice. Thank you. Now, we have one of our partners coming for a brief presentation. I call on, as we acknowledge, a presenter from Everright Healthcare Foundation, Mr. Onyeka Ewuzie, the National Business Development Manager of Everright Diagnostics and Lab. Can we give him a round of applause as he comes on?
afternoon, distinguished ladies and gentlemen. My name is Mr. Ewuzi Onyeka, the National Business Development Manager of FRI Diagnostic. I want to say that I appreciate what we are discussing here today. It's a very key topic, humanizing healthcare in Nigeria. I just want to draw our mind to what used to happen in the village those days, where you have two doctors, and one with a long you have one with several people waiting, while another doctor, you have just few persons waiting. And then you ask yourself, why do we have several other persons waiting to see this doctor while we have few? It's just a matter of how these other doctors has been able to manage the relationship with the patient. That's exactly what we are talking here today. The truth about it is that you will understand it more when you have had the experience. I've been there. Have the experience of managing a patient, a relation, being a caregiver, standing with a patient while that patient passes on. And then one of the things that goes through your mind is, how was this patient managed? You know, so I'm happy we're having this, and my advice is that there is need for us to have more sensitization so that more people will get involved in this. But the truth is that the major challenge we are having, I used to talk to some of my staff. I said, if any patient walks into a facility, the facility is not an entertainment environment. What it simply means is that no patient should actually be wrong for whatever reason. Manage that patient at that key particular time, and then manage your own emotions. That is where the relationship between the patient and the doctor, that's the borderline. Now, I want to talk about FRI Diagnostic. FRI Diagnostic is one-shop lab where virtually everything is done, every test that you can imagine. And our focal point has always been those medical tests that you go outside Nigeria to carry out. And why did we come out about this? Why we came about this is we needed to minimize medical tourism. And that's the more reason why in FRI today, there is hardly any test. There is hardly any test that is not carried out in FRI Diagnostic. And as I speak to you today, I can tell you most of the major hospitals we have here in Abuja and beyond, we handle their medical tests, particularly those tests that are sent outside Nigeria. I also want to say this, that we have moved a step further to go into next generation sequencing. Now, what we've been focusing on in recent time is advocacy, making people understand why preventive medicine is very key in recent time. I've had the opportunity of going to a national hospital, and then you see several number of persons with cancer-related ailments. And the most challenging thing is that, I will just tell you my personal experience. I lost my wife in October. Now, what happened? She had cervical cancer. And then a test, some of the things that were supposed to be done, radiotherapy, for example. We came all the way from Port Harcourt, and then we were told that the medical equipment in National Hospital broke down. We had to go all the way to Lagos to do the radiotherapy. And we also asked to register for the brachytherapy. We came down to Abuja only for us to hear again that it's broken down. And I can tell you that the radiotherapy machine that we have, record says that we have just 3 in the whole of Nigeria. That is Abuja, Maiduguri, and Lagos. What does that tell you? What it tells you is the essence of preventive why do we want to wait until we fall sick? That is what Everett is advocating for. And in recent time, we have taken it as a task to go to different organizations to carry out health education and counseling. The whole idea is, why not develop this as a consciousness from time to time, at least twice in a year, to find out about your medical status, so that you don't have to wait. I can tell you that I personally spent over 30 million, and yet I lost my wife. But the truth is that if that test had been carried on long before the time it manifests, one is that I would not have lost her. Secondly, is that we would not have gone through the pains that we went through, going from one hospital to another. I want to use this opportunity to tell you that we also have a relationship with doctors across board. And one of the things I'm advocating here today is that we'll have that mutual policy. We'll have a policy that, gives us, brings Everett Diagnostic and the doctors together. And what are we saying? What we're saying is that we have the point to manage your patients, and at the end of the day, we have mutual benefits. I want to use this opportunity to crave your indulgence to have that business relationship with us. I would like to drop my number, because there are some certain things I may not be able to communicate with the doctor directly. But I want to hope that we'll have the opportunity of sitting down with you and discussing the business element where we can manage your patients, and at the end of the day, you have that benefit of enjoying what several doctors or several medical hospitals has actually enjoyed with Everett. The number, can I give out my number, please? The number is 080 33 25 9344. 080 33 25 9344. Can I also crave your indulgence to visit Everett Diagnostic? Can I crave your indulgence to visit Everett Diagnostic so that we'll have the opportunity of taking you around and showcase what we have? We are one-shop lab where practically every test is done. Thank you very much.
Please, a round of applause.
All right. So I'm going to take this moment to appreciate some of our sponsors. We want to appreciate Dateline Health Africa. Can we give a round of applause? Bio Royal Hospital, MEV Specialist Hospital, Alliance Hospital, and as we've just heard from the development manager, Everett Healthcare Foundation. And for a bonus, the Care Conversation podcast. I applaud now. This is one of the subsets of the Patient-Doctor Forum. I think one of our panelists alluded to having certain conversations or forums where, patients get to talk, we hear their purview, and doctors. To some of you who know the Care Conversation podcast, championed by the Patient-Doctor Forum, we have a platform where we have conversations you don't hear often, from the patient side, from the doctor side, from unique trends and scenarios. And if you're not aware, you can always chime in from the YouTube and Instagram page to follow on all platforms. Thank you. I think for the next, as we start to slowly wind down, we'll do some key insights and wrap up. All right, so for the goodwill message from Everright, I think Mr. Oinker just was sending now.
Yes. So, okay, he's left. Okay.
Thank you, ma'am.
Sorry for the mix-up. Good afternoon, everyone. I stand on existing protocol and want to appreciate everyone that has been here. Indeed, it's been a great insight to what we do in the healthcare system. And if we continue to advocate for more empathy in healthcare delivery, I think we'll definitely have a smooth ride. And all of this call for policy changes, it starts with us. And just as someone rightly pointed out, because while the discussion was going on in my head, I'm like, it goes beyond the doctors. Healthcare actually goes beyond the doctors. And if we work in the hospitals, we know the first people we meet. If we educate the gatekeepers, from the security people to the receptionists and to the nurses, before you even get to the doctor, I think this communication starts. And while we are also inaugurating this PDF and advocating for better conversations, for better care, I think we should extend this knowing that communication is beyond verbal. We also have the written communication, just as Daddy pointed out, the writings. If your patient cannot understand what you're writing, I'm one person, a mother of 3, and all through my interaction with my pediatricians, I made sure that I understood all the drugs. You must tell me and explain in details what each drug does and the implication if I am not adherent and if I don't do the needful. So even when the nurses try not to make me handle the folders, I insist. Let me handle my folder. I'm not crippled. I'm not handicapped. And so let's understand that this communication goes beyond the one-on-one conversation, both the written, both the messages on media and all of that, and both the body languages we put up and our nurses, all of that. So in Everright Healthcare Foundation, we have prioritized community diagnostic care. And we were glad when Dr. Temitope approached us to have this partnership. It's our great honor to sign up this partnership with them because beyond the 4 walls of the hospital, we've discussed that into the communities for the underserved, we prioritize their care. And we start by advocating preventive care through our community diagnostic approach. We want to drive that seriously with PDF Nigeria to make sure that the community healthcare system is excellently delivered. And just as our sister rightly cried out, the mortality rate amongst the underserved population will be drastically reduced. Thank you very much. It's a welcome development, and please let's support to drive this project forward. Thank you.
Another round of applause. With a show of hands, can I just see someone who was glad they were here? Okay, I'm looking for people that didn't raise their hands.
All right, thank you so much for finding time out of your very busy schedule. This is a conversation that we need to continue to have. I would have said we should stand up for a standing ovation for the founder of
the Patient Doctor Forum Nigeria.
Yes, and then also for yourselves, honestly, we need to do that. Thank you so much. All right, so just for the wrap up, because we're all exhausted now, and for me, we're about to have a safe landing. Before we started, I told us to fasten our seatbelt, right? And we're about to have a safe landing. So I think we should fasten our seatbelt for that. We've had an insightful conversation today, yeah? And the theme of the forum has been one that we have been having personally in our head. So I want that at the end of today's conversation, the hospital will not be crowded like Wuse Market. Yeah? And my doctor will have time for me and we can have a meaningful conversation. And I won't have 5 people hiding behind the doors so that I can be able to also meet up with my own appointment and not have to come the other day. We started today's conversation with a welcome remarks by Dr. Olu Akerele, and what he said was quite really insightful. And then we have Dr. Akin Moses here, who gave us his keynote address. And one of the things we learned, communication has been at the heart of his keynote. And then we had goodwill messages from Dateline Healthcare, yeah? They were here and they supported the conversation and the conveners of this very important inaugural forum. And then we had unveiling of the books, which was the highlight for me. And I said I wanted to live here selling all of my books. I can see quite a number of it, and I'm sure before we leave, the production cost, the sales cost is not much. I think it's 5,000. We can still do better.
You can gift it to someone that you think needs it.
And then you can visit Adam's pages, of course. We have copies there. And then we went with the first panel session, which took us to exploring barriers, talking about real stories, rebuilding trust between patients and doctors, because if there's no trust, there will be a break in communication. And if there's a break in communication, we can't get good diagnosis. And if we don't get good diagnosis, the system will be broken. And if the system is broken, we are all abettors. That's simple. After that, I think we had the lunch and networking, right? And then from the lunch and networking, we have Dr. S.B. Tanko, who gave us that good moderation of the panel session, designing healthcare system that enables better patient-doctor communication. And my takeaway from this very conversation was the issue of training and retraining, right from the gatekeepers down to every single doctors and the patient. I think patients even need more trainings. I don't know how that can happen. We used to have Parents Teachers Association. If this forum is one of such a forum that buys into that template of a Parents Teachers Association, where they get to talk about the issues around them, and that takes care of it. And then we had the partner presentations as well, which was quite really remarkable. And then we have the sponsor acknowledgement by my co-MC here. And those are the takeaway from me. And so for the vote of thanks, can you please invite who we have for the vote of thanks?
Okay, so we invite for the vote of thanks Dr. Emmanuel Bolarima.
Please a round of applause.
Please a round of applause. Thank you so much.
Good afternoon, everyone. All protocols duly observed. We thank you everyone for coming. We thank God for making us see the end of this program and for all the important things we have learned. I wouldn't want to run through everything we've talked about. The moderators have already talked about everything we should take home from this program today. I want to believe that next year we'll come back bigger and better, and by that time we will have solved most problems which we have identified today. I want to thank all our policymakers for coming, for taking time out to come today. I want to thank our trainers, our employers, the convener for having this vision. Thank you so much. Thank you for involving me personally and other colleagues for putting us together to come and form this forum. I want to thank all our volunteer doctors from various hospitals for coming and being part of this. Thank you so much for all you've done. And thank you for our patients that also came out today. We hope we have all learned something today. Thank you very much. Thank you.
Thank you, sir. And for just a few final words, we invite the convener of the Patient Doctor Forum as we wrap up the inaugural event of this great initiative.
Yeah. Thank you so much. Now I can sleep. Let me tell you a secret. I didn't sleep overnight, actually. But finally, after 5 months, I can sleep. I want to thank you all very much, especially for those of us that have stayed until now. Thank you very much, sir. My uncle, you have been so much of a support. Most of the special guests that have come, you're the one that brought them. I'm so grateful, sir. Thank you so much. And you even stayed till the end. I'm so grateful, sir. Thank you very much. So I want to thank Dr. Bolarewa, thank you for that address. And then all other board members. I think Dr. Sonny is still here. Dr. Sonny, please just wave. That's our Director of Communications. Dr. Dewusi, she's still here. Okay, that's our Director of Stakeholder Engagement. And then Dr. Umba, okay, she's no longer here. And then we have Dr. Akerele, of course, who is an advisory board member. And Dr. Ebuta has left now, but is also an advisory board member. I hope I didn't leave out anybody. That's all of us, right? Okay, yes. Okay, and then the volunteers. Thank you very much. Any volunteer inside? I know some of them are outside. Okay, thank you very much. I'm so good. I couldn't have done this without you. Thank you so much. Our panelists that are still here, Ms. Omotade Victoria, thank you. Dr. Okechukwu, thank you. Thank you so much. Dr. Lawson, thank you so much. Thank you so much. Dr. Jamila, I don't think we identified or we recognized you. Thank you so much for coming. We just invited her. We saw her online, we invited her, and she came. Thank you so much. All right, thank you, everybody. Let me not go on and on. I'm trying to scan through. Dr. Laguju, thank you so much. Thank you. We really appreciate you. I got the alert from MEF Specialist Hospital. Thank you so much. We appreciate you. So, till next year, I guess. I hope that by next year, okay, we're going to high CC, yeah? Yeah, so thank you all so very much. God bless you.
Thank you all. God bless you as you made way to go back home. May God reward you for coming and a safe journey back to your various destination. I promise this event will end at 3, and I hope I did that. I hope we never crash land. So my name is Salamatu Sule as we land. Thank you so much. Thank you. And to my co-host, it's been a wonderful journey, right?
Pleasure is mine.
Thank you so much.
Quick one. Please, we want to see your pictures online. # Patient Doctor Forum Nigeria. And your feedback. Please, we want to hear from you. Feel free to follow us on all platforms. And on Facebook, Instagram, Twitter. We are active, YouTube, on all sites. And you can also subscribe to the Care Conversation podcast. And lastly, have a wonderful evening. Thank you. Can the media please put up the feedback form so people can give us feedback? We have a link and a code so we can scan and drop a feedback. We'd love to hear back from you on what this event meant to you and anything you want to add. Thank you.